I hope you all had enjoyed the lunch. And now I look forward for our next session, iPhorum Case 1. That is the case of recurrent vomiting. And I would like to call our panelists, Dr. Rajneesh Gulati, Dr. Anupama Nagar, Dr. Aravind Gobi, and Dr. Arun Karyampudi on stage. And our discussant for the session, Dr. Umesh Goyal. This is a reminder call to all the participants of Manometry Pathshala workshop to kindly reach out to their respective co-meeting areas. Thank you.
Okay, good afternoon, everyone, and welcome to the panel discussion on recurrent vomiting, which is not the right thing to do after lunch, but whatever they have suggested, we'll follow that. Okay, so today's agenda, I'll discuss the few definitions relating to vomiting, and then the pathophysiology in brief, and then we have a case-based discussion in which we'll discuss how to move as in a case who has recurrent vomiting, how to investigate, and we'll focus on the gastric emptying studies and the motility tests, and then we'll know how to manage such a case. So to begin with, this is a just basic definition. The nausea we know is an unpleasant sensation of impending vomiting, but when the person doesn't vomit, that's called nausea. And vomiting, which is a partially voluntary act of forceful expelling the gastric or intestinal contents through the mouth. And the other relating things are, it's called chronic when the duration is more than 1 month. We say it's patient of chronic vomiting. Retching is a active and repetitive spasmodic contraction of abdominal muscles with the glottis closed so that nothing comes out of the mouth. So that is called retching. And so a patient may have multiple symptoms together. Patient may have nausea, retching, vomiting also, or a patient may have just one symptom. The other things which we need to label in our OPD is whether the patient has regurgitation, which is effortless reflux of contents into the esophagus. That sometimes reaches the mouth, but rarely it's expelled. And then rumination, is we all know, is a regurgitation of partially digested food, which comes to mouth and then goes back. So these are things which we need to know to label a patient symptom correctly. We know there are multiple components in the process of vomiting, and neurological coordination is done by the vomiting center, and we have role of higher centers, or we have the role of LES. So I mean, anywhere the stimulation can be there, which can lead to the act of vomiting. And the main receptors which we need to know, because we need to know the treatment, so we need to know the receptors involved in the case of vomiting. So there are mainly 4 receptors involved: the dopamine receptors, the muscarinic receptors, the histaminic receptors, and the NK receptors. So we have drugs targeting each of these receptors when we go to treat the vomiting. The upcoming role in the recent few years is the role of gastric rhythm and the pyloric function. So this is a new things which we learned today. In the case of chronic vomiting, how does the gastric rhythm affect the symptoms? How does the pyloric dysfunction affect the symptoms? How to diagnose these and how to treat these? Because the basic medicines for vomiting, which I told, which act on all the receptors we have been using, but the patient doesn't respond to those medicines which act on the vomiting center and the other receptors, the patient still has symptoms. So there is possible role of other pathophysiological mechanisms relating to stomach and the pylorus. And the central role in the rhythm is of the ICCs, the interstitial cells of Cajal, which are the pacemakers of the electrical activity of the stomach. And they are crucial for the regular slow wave activity. And the normal slow wave activity is up to 3 cycles per minute. And these are located deep in the muscular rail of the stomach wall. And various pathological studies have shown that, yes, they are depleted, like in a patient of gastroparesis who has recurrent vomitings. When people investigated and the biopsies show that, yes, these are depleted. You can see these brown spindle-shaped cells on the left side of the, they are multiple, they are normal. In the right side, a patient of gastroparesis, they are depleted. So this slide sums up the role of stomach and the pylorus, because when we eat food, we know there is a accommodation here, which where the stored for the food to get stored there. Then there's an intermotility. Then there is a pyloric opening later on to push the food outside, and even the small intestinal motility helps. So when the abnormality of any of these or multiple causes out of these may lead to recurrent upper GI symptoms like nausea, vomiting, etc. So we begin with the case. The case is of a 33 years old female we presented to our institute few months back, and she is a postgraduate and married, a teacher by profession, a vegetarian diet, and resident of Punjab, from where I work. So she had a history of recurrent episodes of vomiting since 7 years, and the frequency was at least 1 to 2 times every day, and or at least 4 to 5 days a week. The symptoms are progressive over the last many years, and most of the vomiting episodes are preceded by nausea, and they mainly occurred after meals and associated with early satiety, and also with inability to finish a proper meal. She had not taken a proper meal, she says, since long, although she feels she has good appetite, and also she feels a bloating sensation in the upper part of stomach. There was history of significant weight loss in the last 7 years. However, there's no history of pain abdomen, no history of blood anytime in the vomitus, no history of loss of appetite, no history of headache, although there was some history of stress related to her job profile. The past history and the family history were not significant. The general physical examination, the vitals were stable. However, she had pallor and she had mild bilateral pitting edema, suggestive of malnutrition. There was no icterus, no cyanosis, and no clubbing. The systemic examination was essentially normal. So at this point of time, without the investigations, my first question to the panelists, how to approach such a case? Like, what should be the initial diagnostic test at this point of time? Dr. Ashish is here. Sorry. No. So, Dr. Arun can take the case. Yeah.
I think first we do the routine testing in all these patients. Includes blood parameters, LFT, KFT, thyroid, and rule out the sort of any metabolic factor, diabetes, HbA1c, blood sugars, and then we go in for endoscopy in these patients and test for H. pylori, and then depending on the finding, one can go for scintigraphy for the emptying time.
So, what would be the threshold for endoscopy, sir, we keep in this case, in such a case?
Although history is sort of quite long, and we may get a negative endoscopy, but we'll have to do it.
I mean, threshold to do endoscopy, I'm asking for the sake of discussion. What is the threshold of endoscopy in a patient who has vomiting of few months? Suppose the patient has vomiting of 4 weeks, some patient is vomiting of 6 months or 1 year. So, what is the threshold time or other factors which you would consider before ordering an endoscopy? I mean,
Any history of weight loss,
yeah.
that is important.
So, any of the alarm symptoms present. So, then with the threshold becomes lower. Even, yeah, Dr. Arun, you'd like to add something?
So the role of endoscopy is to differentiate whether it is an organic or a functional cause of vomiting, number one. So as we all know, if there are any alarm symptoms, endoscopy should definitely be done, and especially when the symptoms for a very short duration. But here we have a case who had been having vomiting for a very long time, 7 years. So endoscopy might not be having a direct role, but in this case, endoscopy will be helpful. The reason is, if we do an endoscopy after a fasting period of maybe 6 hours or 8 hours, and we see some amount of food residue in the stomach, so we can be sure that patient is having a delayed gastric emptying, because not always we'll be able to assess the gastric emptying by all those high-end investigations. But simple endoscopy will tell us whether the patient has delayed gastric emptying or not for finding out any organic causes, which is very unlikely in this case.
Dr. Anupama would like to add.
Yeah, Umesh, before that, a good history is always vital.
Sorry, your voice
A
is.
good history
Yeah.
is always vital. This patient has obviously been in severe malnutrition. So, what is this vomit that she's talking about, she's complaining about? And not many people will have headaches. So, intracranial evaluation is also, I think, one of the important excluding investigations.
Very correct point, ma'am. And secondly, in the history, as you said, more details, history like the timing of vomiting after the meal is very important. If the timing is after 1 to 2 hours, then we suspect obstruction lower down or gastroparesis. If timing is just after the meals, we have different disorders too, so esophagitis and gastritis. And Dr. Arun, I would like to disagree with your point regarding the, finding of food residue. Actually, the studies are controversial. The larger studies have showed that the presence of food on an endoscopic examination has very, very poor PPV, positive predictive value, for gastroparesis diagnosis. So, I mean, we cannot depend on that. Even like if we have food residue, we cannot say it's gastroparesis. If we don't have, we cannot rule out. So, I mean, that is a controversial point. So to move further, so we have to define the vomiting. As I told earlier, it's acute or chronic. The symptoms are less than 1 week, it's called acute. Symptoms are more than 1 month, chronic in between, whatever. So when there's obvious cause for acute vomiting, like some NSAID intake, after some antibiotics, after some GI illness or a part of gastroenteritis, we treat that cause. If there's no cause or otherwise, also we look for alarm symptoms. Again, in chronic case also, if there's some obvious cause, a patient has some intracranial lesion, patient is suppose pregnant and history of vomiting is 4 months, then we treat accordingly. However, if there's no obvious cause, we look for the alarm symptoms. And there is a list of alarm symptoms like the age more than 55 years, unintentional weight loss, progressive dysphagia, persistent vomiting despite medications, evidence of GI bleed, any blood in any amount of blood in vomitus, that should raise the alarm for organic cause, or family history of GI cancer, altered mental status, abdominal pain, feculent vomiting, hematochezia, melena, or some focal neurological deficit. So all these point towards that, yes, there's some organic pathology and we should not delay investigations. So in the general list of investigations, as the panelists have already told, that yes, we should get complete blood count, comprehensive metabolic panel, lipase, TSH, random blood sugars, and other metabolic tests I'll show on the next slide. Then stool test optional according to case. Like if the patient has diarrhea also along with that, then you might go for a stool test earlier. Abdominal radiology, depending on how strongly you suspect some obstruction or other pathology. Abdominal ultrasound, like it all depends on case to case scenarios. So these tests list, like ma'am said, intracranial hypertension, so you should get a CT head, and then endoscopy, yes, if alarm symptoms are present. So you have to tailor your investigations, initial investigations, but the basic investigation which should be done obviously in such cases are all hematological workup, including blood profile, pancreatic, liver, and renal function tests. A simple X-ray abdomen can be done in such cases. So even early obstruction, low-grade obstruction can be picked up before going for a CT scan. So in our case, we got all the she was carrying actually all the investigations because she had been going to multiple places for last 7 years. So her HP had been persistently low. The TLC platelet count were normal. The biochemistry was all normal except low protein and albumin. We got a UPT which was negative, and we got her anti-TTG test, which is common in our northern part of India. So we got that also, that was negative. Upper GI endoscopy had been done twice, so we did not repeat that, and that was always normal. Nothing, no significant ulcer or erosions reported. Her H. pylori test by RUT again 2 times were normal, and ultrasound abdomen was also normal. So with these investigations, I would like to go to the second panelist. So what is the differential diagnosis at this point of time before going to further investigations? What all can we keep, and how do we define these disorders?
Yes. So clearly, this case is a, doesn't, we have ruled out an organic cause such as obstruction, raised ICT, and so on. So this case is a functional, or we can call it as a functional or a motility disorder. So I can see you have listed 4 causes, but functional dyspepsia doesn't fit because usually vomiting is not a symptom of functional dyspepsia, whereas all others can be considered in the differential diagnosis of this case, that is cyclic vomiting syndrome, chronic nausea vomiting syndrome, and gastroparesis. So the problem of picking one of these 3, like it would be difficult because there can be significant overlaps with each other. Usually, if you look at the cyclic vomiting syndrome criteria, they usually happen intervals, and
So I can just go to criteria, Arun, Dr. Arun, you can lead,
Yes,
or
yes.
maybe, yeah. So after the Rome 4, very rightly said Dr. Arun that It either could be a functional disorder at this point of time, or we can say, or it's a motility disorder like gastroparesis. So, if we see the functional disorders list out of all the upper and lower GI disorders, the disorders which relate to more of upper GI, persistent upper GI symptoms are functional dyspepsia. But yes, vomiting is not a major symptom of functional dyspepsia, so that may be out. Belching also does not involve more of vomiting. We have discussed in the previous session. So what we are left with out of these is chronic nausea and vomiting disorders, in which we have a syndrome called as chronic nausea and vomiting syndrome, cyclical vomiting syndrome, cannabinoid hyperphagia syndrome, especially in patients who take cannabinoids, and rumination syndrome. So how do we define these? So functional dyspepsia, I'm saying again and again because it's a commonest upper GI disorder. So we should know how the correct definition and how to define that. So in the Rome for it, it is defined as presence of at least one of the four symptoms. That is PDS type of dyspepsia, in which we have postprandial fullness or early satiety, and the EPS type of dyspepsia, in which we have epigastric pain or vomiting. And the criteria should be fulfilled for at least 3 months, with symptom onset at least 6 months before. And obviously, all organic pathology should be ruled out. And the two subtypes which I told is PDS and EPS, they might even overlap. The chronic nausea and vomiting syndrome is defined as bothersome nausea and vomiting occurring at least 1 day per week, and it is a self-induced vomiting. A patient has eating disorders. Self-induced vomiting, eating disorders, and regurgitation are excluded in these patients by history, and there's no evidence of organic, systemic, or metabolic cause to likely explain this. And again, as with all functional disorders, the criteria should be fulfilled for 6 months duration, and at least 3 months active complaint should be there. Cyclical vomiting syndrome is a typical syndrome in this stereotypical episodes of acute vomiting, and duration of less than 1 week, and 3 or more episodes in the past 1 year should be there to label this, and at least 2 episodes in the last 6 months. So this clearly our patient doesn't fit into this type of syndrome because she had persistent vomiting throughout the year. She could fit into this CNVS syndrome. And in this cyclic vomiting syndrome, yes, supportive criteria is the family history or the personal history of migraine. It supports the diagnosis of cyclical vomiting syndrome. Then there's an entity called chronic unexplained nausea and vomiting. So this is after a partial workup. It's a symptom complex again, which has same symptoms of nausea and vomiting, normal diagnostic testing, normal metabolic profile, normal upper GI endoscopy, and even 50% will have normal scintigraphy study. We'll go to this study later on. Gastric emptying study might be normal, and these patients do require further advanced testing, which we'll be discussing later. Then gastroparesis, as Dr. Arun said, yes, this is not a true functional. This is not a functional disorder at all. This is an organic disorder, but it's a motility disorder of the upper gut. So it's a gastric motility disorder in which specific symptoms are there like nausea, vomiting, bloating, postprandial fullness, early satiety, abdominal pain, and the vomitings are typically recurrent. And in this, when there's objective documentation of delayed gastric emptying with solid food and mechanical obstruction has been ruled out, then with imaging studies and with upper GI endoscopy with radiology, then we can label the patient as gastroparesis. But symptom-wise, yes, our patient does fit into this also. So this is an important slide showing that how the symptoms and the pathophysiology even of functional dyspepsia and gastroparesis overlap. If you see in the middle, the common phenomena in these two disorders are delayed gastric emptying, impaired gastric accommodation, visceral hypersensitivity, and abdominal duodenal feedback. While the factors specific to functional dyspepsia are duodenal inflammation. There's an upcoming role of duodenal inflammation, especially duodenal eosinophilia in patients who have persistent dyspepsia, altered central processing, gastric bile acid hypersensitivity, and the physiological method things typical to gastroparesis are anteroduodenal dysfunction. That means there's a discoordination between the antrum and the duodenum, pylorospasm, macrophage dysfunction, gastric pacemaker, that is ICC dysrhythmia. So they have overlap, and they are different entities. They have symptom overlap, they have some physiological overlap. So my question to Dr. Anupma, what investigation should be done next in our patient who has all metabolic profile normal and the patient has endoscopy normal?
Yes, there are several studies that are available to look at a function of a stomach. The simplest one is gastric emptying time, where you give a person a defined quantity of a liquid meal and look at his or her reaction. The new kid on the block, EGG, which is now available in several centers in India, is again an attractive alternative. difficult tests are enteroduodenal manometry and endoflip, but they do have a role to play in assessing the function of the stomach.
So very rightly said, the standard gold standard is gastric emptying time. Now, may I have a show of hands? How many centers are? How many people are doing GET studies in their centers? Maybe just 5 or 6, 7, 8. Okay, and EGG almost same, but the centers are different. Those who raised hands for GET have separate hands for EGG, so that's good. And anterodural manometry, no, and endoflip is not available in India yet. So yes, the standard gold standard remains the GET. Now I'll just try to discuss all the things one by one. So now we discuss the test to assess gastromotor and myoelectric function. The first subgroup of test is the test which assess gastric emptying. So there are more tests beyond scintigraphy. So scintigraphy is the gold standard as highlighted, and it is a non-invasive test. But the only problem is of radiation exposure, which is yet minimal. The other two tests which have been approved in the US FDA has approved breath test and also the smart pill, but these are not available in India yet. So what is done in these is the carbon labeled with acetate, octanoic acid, or spirulina, which is edible algae. That is given, and the patient and the breath is tested for the radio label isotope. And the only problem with this that patient should have normal small intestinal absorption also, because these things will go through small intestine, then liver metabolism, and then come through the chest breath. So we need to have all organs working properly to get this test done, and it's a non-invasive and easy to do test. Then wireless motility capsule, also called the smart pill. So it is not only for stomach, it is for the whole GI tract monitoring. It monitors the pressure, the pH, and the temperature outside the gut. So with this, we can even calculate the whole gut transit, and gastric transit, small gut transit, and the colonic transit time. Everything can be done with a single go. And this is also, I think, not available in India till now. It slightly should be expensive. And the other tests which were done previously, or which can be done if other things are not available, is ultrasound for serial changes in enteral area after giving a meal. However, it requires expertise for imaging and training for that. Then MR, again, is a non-invasive. However, it might be expensive, time-consuming, and again needs a special software. A normal MR machine cannot find that because it will be a dynamic study. Upper GI barium and radiography are almost obsolete now with the advent of other investigations, which is just a thing to label here. So just few slides regarding scintigraphy. So the only thing which we need to need is to see that is to stop all medicines which affect gastric emptying 48 hours before the test, and we have to check blood sugar, and or if patient is diabetic, then control the diabetes before going for this test. The most commonly done is the low fat 250 calorie test meal, and it was typically in the West they started as a low fat egg white scrambled meal, but for vegetarians in India we do have vegetarian meals also prepared which we can give. And the imaging has to be done at 1, 2, and 4 hours. So the protocol is standard to avoid radiation exposure. It is done at 3 times only. And the criteria for labeling as delayed gastric emptying is retention of more than 60% of the radio labeled isotope at 2 hours and 10% at 4 hours. Although the newer guidelines, the new data says that to diagnose gastroparesis more stringently, the criteria might be raised to 75% and 25% respectively. And then at 4 hours, if the retention is 10 to 15%, we label as mild gastroparesis, 15 to 35% moderate, and more than 35% retention at 4 hours is severe gastroparesis. This has implications on treatment, which will come later. So how much retention at 4 hours has implications on treatment and symptoms.
Are these values for Indian patients, or
Sorry?
they're standardized for Indian patients? These values?
No, we don't have any Indian data.
So we don't have any Indian data to label them as a
I think, yeah, few small studies were there. You might like to add.
PGI Chandigarh did establish a gastric scintigraphy using Italy,
Yeah, Italy.
which we follow in our center. But I don't know about other centers.
No, we
but
also follow Italy meal in our center, but we use the same data actually. That the patient number was less in that, and they could not give us the Indian data. But meal is standardized now, Indian, the Italy meal, which we use.
But there are problems with these studies, as Umesh will elaborate.
Definitely. So, but still, this remains the gold standard and gives a fairly good idea of the amount of gastroparesis. The second test, uh, which we, as we discussed, are not yet done in India, are the intraduodenal manometry. These are almost they give some additional information, and they are complementary. They are additive to the scintigraphy studies because each test diagnoses a separate set of problems which scintigraphy might not tell. Scintigraphy will just tell that it is delayed. Delayed, why? So these tests will give us some further answer. Where is the problem lies in the stomach, in the pylorus, and so what is happening to those organs. So the and manometry assesses the contractility in fasting and postprandial periods. It is invasive because you have to insert a catheter and needs expertise to perform and interpret. The endoflip, I'll be coming in the next few slides. It's a novel technique. How is it done? I'll discuss. And the gastric barostat is merely a research technique, not done clinically. So these tests will tell the gastric and the pyloric functions. So if we see these three test motility assessments, so first of all, I'll discuss this gastroduodenal manometry, in which if there is abnormal organization of normal contractions, and the persistence of fasting motor patterns after meal ingestion, they will give suggest a neuropathic disease going on. When the contractions are low amplitude and the number might be normal, they indicate a myopathic pattern. And now, when we do a high resolution water perfused antropyloroduodenal and jejunal manometry, it will give us further information of the problems in antrum, pylorus, or small intestinal dysmotility, and which will aid in selection of therapy. The third, endoflip, I'll show images later, but the utility is mainly the assessment of pylorus. As in the morning session, some you might have seen the endoflip was being discussed for esophagus. It's the same device. We take it to the pylorus, so it will tell us about the distensibility of the pylorus, the compliance of the pylorus, and the in cases of pylorospasm in which there's a problem in pushing the food out of stomach while the stomach wall might be normal. So this will guide us performing invasive procedures like GPOM or pyloroplasty, which I'll be discussing later. So this is the utility of these three techniques. This is a picture showing the endoflip balloon being placed across the pylorus, and in this, the endoscope is not to be passed. The balloon is inflated slowly at the rate of 1 cc per second, and at various phases of 20, 30, 40, and 50 cc balloon distensions, keeping it for 5 seconds, the recordings are taken, and then the software gives such a picture, as you must have seen in the esophagus, which tells about the distensibility of the pylorus and the compliance of the pylorus. So basically, it will give us information about the pressure around there, the diameter, the cross-sectional area, and distensibility. And these two techniques, they have really demonstrated that the role of pylorus in chronic nausea and vomiting cases, which was still yet not recognized, because till now gastroparesis meant slow stomach movement. We just meant the stomach is not moving, but the problem might be both also or single also. So in patients of now even diabetic gastroparesis, in which there's a real gastroparesis going on, the stomach is not moving, the pylorus is also not opening. So the reverse is happening, and both things lead to compounding of symptoms. This is another research technique going on in which the high resolution electrical mapping is done by placing electrodes over the serosa. It's a very invasive technique. Through laparoscopically, they place the electrodes over the serosa. And the same is being done now with mucosal technique. By endoscopy, you place the electrodes all over the stomach and you see the movements of the stomach. You can diagnose dysrhythmias, but this is still a research technique. The third group of tests which assess the gastric myoelectrical activity, called the GMA, is the EGG. So EGG is a really non-invasive test in which we place the electrodes as shown here over the antrum and the stomach area, and patient is first fasting recordings are taken, then test meal mainly water is given. That's called a water load test, and after that the frequency of contractions is checked, and regularity of gastric myoelectrical activity or irregularity is we come to know from this EGG. So this EGG, how is it helped is that it correlates with the amount of ICCs present in the stomach. So as we discussed initially, ICC is the pacemaker of the stomach. So what happens, EGG recordings and when the biopsy studies have done, they showed that yes, when there's the depletion of ICCs, it leads to gastric neuromodular dysfunction, and which further leads to delayed gastric emptying. So EGG recordings have they correlate with the amount of ICCs, and the normal 3 cycle per minute GMA activity occurs when ICCs are normal. If they are low, there's a bradygastria. It's just like of bradycardia in the heart. We see this low rhythm is bradygastria. So the stomach rhythm is the frequency of stomach contraction is low, and when the ICCs are high or there's some other problem, it could lead to tachygastria. The rhythm is higher. The 4 step of test, which are not very clinically relevant, are mainly of research protocol. Again, are gastric barostat and satiety tests. Other tests, again, which are upcoming, again, not available in our country, are the special SPECT and MRA measurements of the after taking a meal. We measure the movement of the meal through these techniques, and they indicate the gastric accommodation, and the emptying rates maybe we can judge from these techniques. Then again, taking a full thickness biopsies of stomach or small gut in patients if we suspect neuropathic or myopathic disease or ICC loss, again done in research protocol. So in our case, we did a gastric emptying scintigraphy study, which showed significant delay in emptying of solid meal, more than 20% retention at 4 hours. And then we did a EGG study. Now this I would like to show the tracings. This is a real life case in our lab which we did. So in this, the gastric rhythm was almost normal at all the 4 electrodes, and there was some evidence of bradygastria after meal. However, there was no tachygastria. And then there's a score which the software calculates. That is called the gastric myoelectric activity threshold score, GMAT score, and the normal value is less than 0.69. So this patient had a very high score. So what does this score mean? This score means the stomach is pushing the contents, trying to push the contents at a proper, more than normal rate, but the pylorus is not opening. So this indicates this high score is a composite score from all the factors, and this indicates this patient is suffering from entropyloroduodenal outflow obstruction. So this is the diagnosis, is a new term which is labeled after this EGG, entropyloroduodenal outflow obstruction. That means the patient is not able to push the food despite normal gastric activity. So Dr. Arvind is here. Yeah. Sir, your question is what are the next steps of treatment? What are the? Can you enumerate the steps of management of such a patient with gastroparesis, and special focus on dietary interventions?
Okay. Uh, these are kind of patients which require most of our time, an elaborate clinical history and spending time with the patient to understand them better needs significantly we have to give them time. Basically, once some histories are very important. We see this patient is a mental stress patient. She's stressed because of her physical work. All right, probably she could have been not eating well, or she could be indulging in some alcohol. A lot of history is very important. First thing what I would like to see in such patients are adequate lifestyle modification, right? Good lifestyle modification and the dietary interventions. That is more important for me. So I would advise her a good lifestyle modification. And second thing is, I would just go ahead and start her in a small dose of metoclopramide, and or it could be domperidone, and see and how they respond very well. So if it is a mild symptoms, they should come back to me saying that they are doing well, and of course prokinetics also should help them. But however, all said and done, in case if they fail such medical treatment, probably I would like to go ahead and consider endotherapy.
Very right, sir. So we have to move step by step in a patients of mild to moderate cases, and with short duration history. We should first try with dietary intervention, which should be the low fat and low insoluble fiber diet. That we have to use soluble fibers, or the fiber that is cooked and reduced to small particle size, because whatever problem is there in the stomach and pylorus, this thing might be helpful in that, and that should be homogenized. Plus we should give supplements for and vitamins to these patients who are chronically having nutrition loss. We should avoid all triggering foods and maintain a good hydration. In cases of severe gastroparesis, in refractory cases, then for feeding purposes, we have to do some invasive procedures like placing a nasogastric nasovaginal tube or a gastrostomy tube, and peg tube, or etc. The pharmacological options are basically of 3 types. One is prokinetics, second is antiemetics, and third is neuromodulator drugs. So prokinetics are basically the drugs which enhance GI motility, while antiemetics are specifically those drugs which lead to decrease in emesis, decrease in nausea, but without affecting the GI motility. So the first group of drugs act as mainly the most common group is anti-dopamine receptor antagonist, which we are using domperidone, metoclopramide, levosulfide, etopride. The second receptor, which is important, is 5-HT4 receptor. It's wrongly written here anti. It should be agonist. 5-HT4 receptor agonist like prucalopride, mosapride, levosulfide, metoclopramide. So these drugs help in increasing the motility. The third group of drugs are the renin receptor agonist and the motilin receptor agonist like erythromycin and azithromycin, which are antibiotics otherwise, but can be used in as a second line therapy in cases where we have decreased gastric motility. Renin receptor agonists are still in phase 3 and 4 trials, not available for clinical purposes. And 5-HT3 antagonists are basically antiemetics. They do not affect the motility that much, but they help in emesis. Then NK receptor antagonists are the new class of drugs which help in preventing nausea and vomiting, mainly in chemotherapy cases, but can be used in such cases also. Busparin is not used because it has a lot of side effects, but it acts on the 5-HT1A receptor. And cannabinoid receptor agonists are used in special cases. So these are group of drugs which act on various receptors and can help in improving the symptoms. If I list the prokinetics here, so metoclopramide, the oldest drug, it is still the first line drug in US because it is the only prokinetic approved in US. The only prokinetic. We are lucky that we have so many options here in India. There no other drug is available. Domperidone, etopride, levosulfide, nothing is available. So they still mention this drug to be used in cases of gastroparesis, but they have a limit of 12 weeks. After 12 weeks, it carries a black box warning because it has significant CNS side effects, extrapyramidal symptoms, tardive dyskinesias, and which some of them are irreversible. So in our country, I don't think we need to use this except for a short duration, but it has a better efficacy than all other drugs. So we might use it for a shorter duration with monitoring of side effects. Domperidone is a very good alternative to metoclopramide, and it does not have any central side effects, but it has very severe and life-threatening cardiac effects like arrhythmias and sudden cardiac deaths. So it has been withdrawn from the US market after reports of sudden cardiac deaths in females basically who were using higher doses to induce lactation. So basically at 30 mg, what we use normally, they do not cause any side effect. While if the dose exceeds 60 mg, it can lead to sudden cardiac death by QT prolongation. So this we should all keep in mind and tell our patients, because patients are in the habit of taking that PPA domperidone combination. They don't get relief, they take in evening also. So this is very bad that the combinations are available in which 30 mg domperidone, and if they take it twice a day for a few days, they might suffer from a cardiac issue. Etopride is a relatively safer drug compared to all these drugs because it is devoid of any cardiac or CNS side effects. Levosulfide has good efficacy, but it has again side effects of neurological and hyperprolactinemia. So it should be used with caution in especially young females, and it can also cause impotence in young males. Erythromycin, as I discussed, a second-line agent can be used. It has the problem of tachyphylaxis, otherwise it has good efficacy. And azithromycin, alternative to that, and relamorelin, as I told, is a ghrelin receptor agonist, not yet available in market. More information on prokinetics can be accessed in this book, in which we summed up all the data on prokinetics efficacy in upper GI disorders. Then the list of antiemetics which do not have a prokinetic activity. Out of these, the commonly used drugs are diphenhydramine, ondansetron, and chlorperazine, which have their own side effects. These are the newer antiemetics, some of them transdermal. These are not yet available in our country: granisetron, palonosetron. The third group of drugs are neuromodulators, in which the mainly data is on mirtazapine, which has good action on gastric activity also, antiemetic action also, and also central action. TCAs have not been shown to be very useful in multiple trials. Other drugs like gabapentin, pregabalin, duloxetine can be used on case-to-case basis depending on pain. So we have to target the predominant symptom. If there's pain, we use these drugs, otherwise we avoid these drugs. Other neuromodulators which have some data in chronic nausea, vomiting cases, not in gastroparesis, are olanzapine, risperidone, gabapentin. So Dr. Arun again, what endoscopic interventions now? In our case, the patient has already failed all the medical therapies. She has been on all these prokinetics, antiemetics since last 7 years. Now she has a problem in emptying of the stomach. We have seen in the EGG report, which suggests entropyloroduodenal uh, obstruction. So would you like to go for endoscopic intervention and what all?
Yes. So, endoscopic treatment of gastroparesis is usually directed at the pylorus. So, this patient selection is important. So, we need to carefully select the patient whoever has pyloric outlet obstruction, and you should not offer endoscopic treatment for those who have gastric dysarrhythmia. So, that is very important. So, the therapies that are directed at the pylorus include, number one is Botox injection, number two is balloon dilatation of the pylorus, and number three is G-POEM. So injecting Botox at the pylorus produces some kind of submucosal fibrosis. So G-POEM might be difficult. So what we can do practically is you can dilate the pylorus using a balloon. You see the response. If the patient responds, then he's a good candidate for G-POEM. So if the patient does not respond, then you can expect that he might not benefit from G-POEM.
I'll ask the other panelists any experience on these techniques. Have you performed? Anyone in the audience? How many people might have performed these pyloric interventions? Yes, one, two, two or three, four. Total four and five. Me five. Okay. So right. So very rightly said. The first Botox injection is a temporary measure. Patient effect might last for a few weeks to few months. Easy to perform, can be done. Then the pyloroplasty with balloon, yes, easy to perform and not doesn't require any major expertise, while the G-POEM requires expertise. And then placing a transpyloric stent, which we do not have much data for this. And the other things I'll be discussing in the next slide. The surgical therapies include the same things, but they are more invasive. We do a pyloroplasty or pyloromyotomy. We do the GES. I will be coming later. It can be inserted surgically also and endoscopically also. So endoscopically is preferred because it's less invasive. And then in refractory cases, gastrectomy even has been suggested in literature, who do not improve. This is a device for the patients who have poor gastric motor activity, and it has been FDA approved for refractory cases of nausea, vomiting, and gastroparesis. It modulates the gastric ICCs and myoneural pathways, and it has shown early promise in improving nausea, vomiting, and quality of life. And the other newer perspectives in therapy, which I would like to share, is here that we can combine the two things. Like for diagnosis, we can do endoflip and as we discussed, intradural manometry to have a correct diagnosis. For therapy also, we can combine the pyloric therapies like GES, stimulation and plus pyloroplasty, and then the EUS based placement of GES or this G-POEM. Then the newer drugs I've discussed earlier, and the future trials on immune-based therapies, especially for idiopathic and paraneoplastic gastroparesis, are going on. In our case, dietary intervention with prokinetics and antiemetics failed, as I told. Then we did a balloon dilatation of the pylorus because, yes, we cannot go straight away for G-POEM because it's a quite invasive procedure. We have to see the response first. The patient symptom improved initially, but the record over the next 4 to 5 months, again, vomitings increased. Then we performed a G-POEM and has been 11 months follow-up. She has been asymptomatic. So to summarize, in a patient of chronic vomiting, predominantly which is postprandial, we should ask for timing of vomiting. If it's soon or during meal, we think of rumination syndrome, GERD, eating disorders. If it is after meals, one or more than 1 hour after meal, we should think of gastroparesis and gastric outlet obstruction. We should do a radiology or upper GI endoscopy, CT scan or X-ray to rule out obstruction, and endoscopy also to rule out obstruction. If they are normal and metabolic profile is normal, then we can go for dietary modification and prokinetic agents before moving for a GES, gastric emptying scintigraphy, which is not available everywhere. But yes, if the patients are not improving, we go for a gastroparesis study, in which if it's a mild retention of material, we go ahead with again nutrition therapy and prokinetics plus antiemetics. These might help, and normally they do not require any other therapy beyond that. In moderate cases, again, dietary therapy, control of diabetes if present, prokinetics, adding erythromycin, adding antiemetics step by step, and this helps in almost 50%, more than 50% of cases. If not, should evaluate further. In severe cases, they are less likely to respond to these therapies. We go for further testing like EGG, manometry, endoflip, whatever is available, and then go for these people usually require endoscopic or surgical therapies like gastric stimulation, G-POEM, dilatation, or surgery. First of all, comments by the panelists, and then from the audience we can have.
Erythromycin, you have mentioned this is an oral preparation or this IV preparation?
Which one, sir?
Erythromycin.
Erythromycin, the data when the patient is not able to take oral IV, the dose of 3 mg per kg, 8 hourly. And later, when the patient is not vomiting that much, you can shift to 250 mg 8 hourly. So both things can use. Dosage is less than that of used as an antibiotic.
So very nice presentation. Would you offer G-POEM for a patient who has dysrhythmia or bradygastia or dysgastria?
In that, a patient can have two pathologies together, as I showed. The patient can have dysarrhythmia along with high GMAT score. For only EGG will tell us that thing, or endoflip will tell us that thing. We don't have endoflip, so we should get a EGG. EGG has shown dysarrhythmia, as you told. If there's no an APD, suspicion of APD means antropyloric dysfunction, then there's no role of G-POEM because it's slight invasive procedure. But if we document, yes, there's always a gradient problem. Even if there's not much of retention, we have to reduce the antropyloric gradient, right? If it is slightly high, doing both therapies might help. In patient of dysarrhythmia, doing a gastric stimulation plus maybe a pyloroplasty with a balloon, we can see the response first.
Here the GC-SI score was below 20. So would you consider that also as a determinant factor for outcome of G-POEM?
Definitely, because if the stomach is not moving properly, then the outcome will be less. But we don't have all those therapies available. Ideal would be a GE stimulator device also in this patient, but we don't have that. So whatever is available, we should.
One last thing, in your G-POEM cases, how difficult was closure? Because unlike usual poem, the closure here would be little difficult.
Actually, that is performed by my colleague, so I don't have information on G-POEM, but patient definitely improved, that is for certain.
Thank you.
Right.
So, sir, before performing G-POEM, you prefer dilatation, right, with balloon. So,
Just to
which
see
size balloon you prefer for dilatation?
We use the normal CRE balloon till 18 mm we dilated.
Okay.
Regarding the previous question, the closure of G-POEM can be used with large clips. For normal poem, we use the routine Olympus clips, which are the 11 millimeter clips. But for G-POEM, we use the 16 mm clips.
Thanks for the answer. Actually, I'm not an interventional gastroenterologist, so I don't perform that. Thanks for the answer.
Loop clip technique.
Sorry?
Here.
Oh.
If the incision is like lot of gaping is there, we can use a loop clip technique to close. So it's much easier in the stomach to perform a loop clip technique.
If there are no more questions, we can close the session. Yeah, thank you. Okay.
Thank you all the panelists and the moderator for this interesting case discussion. So next case in our iPhorum is a case of chronic diarrhea. And for this, I would like to invite on the stage the panelists, Dr. Piyush Ranjan, Dr. Uday Ghoshal, Dr. Monica Jain, Dr. Varghese Thomas, and Dr. Neha Berry. And as a discussant, I would like to call upon the stage Dr. V. Jayanti to start the session.
Is Uday around? Okay, while the panelists are taking up the chair, I think Dr. Uday is not come. Dr. Uday Ghoshal is part of the panelist. Uday, where is he? Okay, so I think we'll, without wasting much time, we have our elite panelists. We have Dr. Piyush Ranjan. I think Uday Ghoshal probably is joining. Dr. Monica, Dr. Varghese is there, and Dr. Neha. So chronic diarrhea, you all know. Oh, thanks, Uday, for coming. So chronic diarrhea is a common problem we see in our day-to-day practice, and we're often confronted with the issue whether you're dealing with a disorder that is associated with malabsorption, or is it a disease of functional disorder, or is it part of the IBS? So what we'll do is, I've got 3 case scenarios. Based on the time, we'll see how much we can cover. So we'll be going through these 3 cases. So the basic information in all these, the basic pathogenesis in all these cases is, basically there is the very first thing that happens is there's a bacterial dysbiosis in the gut, and in the presence of genetic factors, there's an increase in permeability, and this is followed by cytokine mediated responses in the submucosa, and that results in the stimulation of the visceral afferent nerves. So going through the first case, this is an IITian who's a trekker. He has been taking food all along when he's gone on for this trekking. And he had, on his return, a severe form of gastroenteritis, and he recovered over a period of 2 weeks. This particular aspect of this disease was discussed in today morning's lecture by Dr. Lee. So most of this has been covered. But he comes about 4 to 6 months later saying that his gut has never recovered since then. And he now says he has gas in the abdomen. Sometimes he's constipated. Sometimes he has to rush to the toilet. And thankfully, he's not disturbed at night. And he also feels there are some triggers with the diet. And he's seen several doctors. He's had blood tests, which included endoscopy and colonoscopy, and treated with mebavirin. And clinical examination was non-contributing. Dr. Neha, can just tell what are we dealing with? Some of it was discussed today morning, but we can just highlight few points.
So, ma'am, this patient is having symptoms which have developed after an episode of an infectious disease of the abdomen. And the symptoms he's having is a cramping abdominal pain, altered bowel habits, loose stools, occasionally constipation. So, my first differential would be a case of a post-infectious IBS, the mixed pattern where the patient is having constipation alternating with diarrhea. However, as he also has a lot of history of gas in the abdomen, a possibility of IBS plus dyspepsia can also be kept. Lower down, very rarely, a first episode of IBD cannot be ruled out.
Yeah,
But
it could
first
still
would
be a red herring. Yeah,
post-infectious
it may be just
IBS.
be a red herring, and maybe this is a precursor for the IBD. Okay, so I think we have to consider all these possibilities, though the one important point that is there in this presentation is the acute gastroenteritis. So, Dr. Monica, what is the criteria that we use? We've heard some of this in the morning to define a post-infectious IBS, and Dr. Uday can just take up. If it occurs within 6 months, the symptom comes within 6 months, and the patient comes to us, what should be the diagnosis? And if it is after 6 months following Rome 4 criteria, what should be the criteria for post-infectious IBS?
Actually, the post-infectious diarrhea, as Neha said, the episode of acute infective illness followed by GI symptoms. This can start after a few weeks, and it can continue for months. To label it as exactly according to Rome's criteria, we need a duration of 6 months. But if a patient is coming after, say, 3 months, we cannot say this is fitting in exactly according to Rome's criteria. But definitely, if we see the natural history of such a patient, over a period of time, say after these symptoms may continue for next 3 months more, then exactly we can label exactly that this is post-infectious IBS.
Yeah, Dr.
But
Uday,
till that time
yeah.
also we consider it as post-infectious IBS, because we have an episode of acute infection in the
is
form
there,
of diarrhea, vomiting, fever, or if culture is positive, 1 or 2 or criteria of these are there. If the patient can say, yes, this was the date, I had this problem, after that I started with these symptoms, probably that is post-infection IBS.
Dr.
The
Uday,
duration may not matter.
Yeah, I think Dr. Uday has a concern on that. If it comes within 6 months, I think in one of your papers you had a comment to make.
I have a point here. See, what happens is this is how Rome defines it. But suppose if you have a patient in your clinic, 3 months later he comes, and now you say go back home, come after 6 months, otherwise you can't give you a diagnosis. So that's why we developed a new entity or rather brought new terminology. When somebody did not fulfill 6-month criteria, call this as chronic bowel dysfunction. Chronic bowel dysfunction. Now, most of these patients, as high as 80 to 90%, continue to have the symptom beyond 6 months if you do not treat them. And the chronic bowel dysfunction terminology we introduced in 1 hour of our paper in American Journal of Gastroenterology. Subsequently, in Rome post-infection IBS diagnostic criteria, it has been accepted. So that means chronic bowel dysfunction we initially proposed and now later Rome accepted it. So you write in your diagnosis chronic bowel dysfunction if 6-month criteria is not fulfilled and treat the patient so that they don't continue to suffer.
So we can use the word functional diarrhea, which is within 6 months, right?
Yeah, so you see when you say chronic bowel dysfunction, it includes everything.
6
But
months.
to call IBS, you have to have 6 months,
6 months.
you have to have pain, not only diarrhea.
So this is a common problem we see in our day-to-day practice, no, acute gastroenteritis. What are the chances that any patient getting acute gastroenteritis can get an IBS or post-infectious IBS? Dr. Varghese, you can comment on that. And what do you think would be the risk factor in such patients that can predispose a person who has an acute gastroenteritis to follow up as a IBS patient?
The prevalence of post-infectious IBS is around 10 to 12% of people who are developing the disease. So if you look at the risk factors, you can consider it as patient-related and disease-related. Regarding the disease, if the disease is more than 1 week, there's a twofold chance. And if the diarrhea is more than 3 weeks, there is fourfold chance of this patient having post-infectious IBS. If the disease is severe in the form of fever with rigor, severe abdominal pain, or blood in the stools, the risk is more than fourfold. If the disease is produced by bacteria, the chances are higher. Viral diarrheas are less associated with the post-infectious IBS. And if it is actually protozoal, there is a very high chance, extremely high chance that the disease will linger on. Now, regarding patient-related problem, younger age, female gender, smoking, presence of background neurotic or psychological tendency, depression, somatization disorder, and a recent stressful event. All these things are considered as patient-related factors which may induce post-infectious IBS subsequently. Some studies have found out that there is probably a genetic susceptibility as well. But we don't have a full paper on that. There's only an abstract on this.
Yeah, so in today morning's Dr. Uday's presidential address also, he mentioned that there's almost, in the first year, there's almost a 4.2 risk of developing IBS-like after an infection, and it reduces beyond 1 year. But interestingly, except for viruses, the bacteria and protozoal infections are the ones that predisposes to post-infectious IBS. That is Dr. Uday's own paper. So this also was addressed in today morning's lecture by Dr. Lee. What are the chances that this particular patient can evolve into an IBD? Do you think they need a surveillance for an IBD, Dr. Uday? What percentage, or should they have a follow-up?
Truly speaking, they do not require surveillance for IBD. But we should be careful. You know, up to twofold rise in the frequency of IBD among these patients than healthy control. So therefore, keep that in mind. Also, it is possible that this patient had IBD at the beginning, maybe asymptomatic, and the infection precipitated the IBD. So therefore, before I diagnose post-infection IBS, I'm very careful. I like to do a colonoscopy. We have burned our fingers sometime that we did not do a colonoscopy, diagnose post-infection IBS because there was no blood, and later it turned out to be IBD. So there is a twofold rise according to literature, and always be careful, do a colonoscopy and a fecal calprotectin.
But can this IBS be reversible? This IBS in an infectious gastroenteritis, can it get reversed as a normal person?
Yeah, that's right. So actually, compared to the common garden variety of IBS, post-infection IBS may have a better prognosis. There has been studies from China, from South Korea, which showed that usually 5 to 8 years later, as high as 50 to 60% have disappearance of their IBS.
So basically, the typical characteristics of post-infectious IBS would be, I think most important history is the onset of the symptom. If you're able to get the date or the month, and then the patient follows up with these symptoms, then you should suspect post-infectious IBS. And most of these have a mixed type they don't have a constipation or a mixed or a diarrheal type. And almost a quarter of them do have overlap with chronic functional GI disorder. And extraintestinal GI manifestations are also known to be predominantly more of a bloat or dyspepsia in patients with the IBS type, whereas in other patients, you'll have more of the extraintestinal manifestations. Dr. Piyush, in a patient who's recovering from, we just started this, when should you start investigating these patients? After 3 months, 6 months, he comes to you now at 4th month with symptoms. When do you think he should start?
For this, we should be relying on the clinical features, the so-called alarm features. We should look at blood and stool.
No, he's a patient who's got bloating and he's got some diarrhea. That's it.
So we look at the blood count, CRP, fecal calprotectin, and in the meantime should work him up for celiac disease, and maybe if indicated, we do a colonoscopy. So if the patient is losing weight in the meantime, then we should start working him for other etiologies.
Dr.
In
Uday,
the
your
meantime,
comments?
ma'am, can I ask one question?
Yeah.
One very pertinent issue of waiting for 6 months. Bleeding
Yeah, that's what. So
blood with diarrhea is one of the risk factors for developing post-infectious IBS.
Yeah.
So does it apply in those patients also who present with bleeding in the first episode? So
That's what Uday mentioned. Within 3 months, 4 months will again be functional, but I think we have to be
patients
watchful.
just come with diarrhea, fever, pain, that is okay. But if this is blood to begin with in the index episode, so waiting for 6 months, still does it hold true in
Dr.
that?
Uday, your comments.
Wait for 6 months because patient has been suffering, and if you look at the natural history, most of them will continue beyond 6 months if you don't treat. So no question of waiting. In the index visit itself, you should investigate. And if you look at our Rome algorithm, we said that if the patient has severe symptom, if the patient has lost some weight, also exclude post-infection malabsorption syndrome.
So I think I've just drawn this algorithm. So if he recovers completely, there's no issue. But if the symptoms remain for 3 to 6 months, then you try to see whether he fulfills the Rome 4 criteria. And if it does so, then you think of post-infectious IBS. And then, as Dr. Uday mentioned, see whether the symptoms are severe, whether there's weight loss, and so on. And if that is so, if it is present for more than 1 month, as Dr. Piyush mentioned, I think we have to push in for investigating other causes of chronic diarrhea. And this also was alluded to by Dr. Uday in his morning presidential address on celiac disease, tropical sprue, IBD also Dr. Piyush was mentioning. So that is important. If they're positive, then we treat them accordingly. However, if it is not there and the symptoms are present for more than 1 month, then you subtype them as either diarrhea or mixed type. And then after reassurance, go for a low FODMAP diet, consider some basic pharmacological treatment. And if it is IBS diarrhea type, we have some of the drugs. For the mixed type, again, ensure that you're not missing a constipation. Constipation usually does not fit in with the post-infectious IBS. At the end of 4 to 8 weeks, you assess these patients. If there's a response, you continue the treatment. If there's no response, consider once again the differential diagnosis for the severe type, and then move them again to the subtype of IBS diarrhea or mixed type. At this juncture, Dr. Uday, can you just tell us, they often keep talking of bile acid sequestration drugs. How do you think it helps in these patients?
Yeah, in general.
Glutamine and bile acid.
In general, there has not been many studies on treatment of post-infection IBS, at least randomized controlled trial. But we all know that almost 70% patient with diarrhea type IBS or functional diarrhea has bile acid malabsorption. Obviously, the bile acid malabsorption includes CCAT test, fecal bile acid, but those are not widely available. So in patient like this, our protocol is first give a serotonin blocker. Serotonin blocker include ramosetron and ondansetron. The ondansetron is the famous study by Robin Spiller from Nottingham, published in Gut. So therefore, if they do not respond, then we add bile acid sequestrant such as cholestyramine. As far as glutamine is concerned, actually there has been only one study from China, randomized controlled trial in post-infection IBS, published in Gut, and that showed fantastic result. But I tell you, the result was too good to believe. Therefore, I will wait for some time to get more trial before I say I'll treat my patient with glutamine.
So to all the panelists, see, all the time we keep talking about this post-infectious gastroenteritis. All these are small bowel disorders, no? But when we stick on to IBS, it becomes a colonic disorder. So Dr. Uday, you're the right person to tell us. No, all the time it is salmonella infection, it's a bacterial infection causing diarrhea, and then you put them as post-infectious IBS. That's a colonic symptom. So what do you think? What do you think is the link between the small bowel and the large bowel? That was one question that came up to my mind.
There could be.
Only thing is, let me. Oh, sorry. You want to say something?
There could be an element of SIBO because, as Professor Ghoshal has always demonstrated in IBS, there is a strong component of SIBO also. So these people also could be having a component of SIBO, and that could explain it. Then we all know the classic example of infectious disease followed by tropical sprue. There is another parallel component, syndrome, that is tropical sprue-like mind. That is small bowel disease is there.
Yeah.
So these two could explain the possibility.
Other thing is, look at this. We try to compartmentalize. We say IBS is a colonic disease and not small bowel disease.
Agree. There's some component of small bowel.
See, the IBS is a disease involving whole of the GI tract. We know that isolated IBS is rather rare. Functional dyspepsia and overlapping with IBS is as frequent as 70 to 80%. Now, patient with IBS, diarrhea, there has been multiple studies. I remember one published in Digestive Disease Science from South Korea, where they took colonic biopsies and they showed there is excess of inflammatory cell in the colonic biopsies. So therefore, IBS truly is not entirely colonic symptom, it is small bowel symptom as well. And second is when small gut pours a lot of fluid into the colon will not be able to adjust to absorb all this fluid, and obviously there is going to be diarrhea which looks like large bowel diarrhea. So this small bowel and colon are overlap, and that explains why they have.
Dr. Piyush, you have a comment?
There are 2 points, ma'am. Dr. Ghoshal would say whether this is true or not. Bile acid deconjugation by small intestinal bacterial overgrowth, does it play a role in the genesis of colonic symptoms, so-called this thing?
Yeah, you're right. Absolutely right. In fact, if there is a deconjugation of bile acid, now this bile acid cannot be absorbed so well, so this bile acid come into the colon. And the small amount of bile acid will actually stimulate adenylate cyclase, and it will work like a secretagogue. Initially, it will not cause malabsorption because steatoric diarrhea will not occur, but choleric diarrhea will occur. And therefore, this is one of the mechanisms, as Piyush rightly said.
Maybe that's the reason, maybe that's one of the reasons why cholestyramine may be effective.
That is why cholestyramine helps.
Maybe,
giardiasis, ma'am, in this list of post-infectious IBS, giardiasis itself causes malabsorption.
Yeah, that's why.
And PI, IBS, we know around 10% of these patients will have malabsorption.
Sure.
And what sounds very, in day-to-day practice, what we see having these patients usually protozoal infections do not have an acute onset. So PI, IBS, post-protozoal infections, again, Dr. Ghoshal.
You see, very important point that is raised. In fact, look at post-infection IBS studies in relation to protozoa such as Giardia. It came mostly from one or two centers from Norway. And look at that, how they excluded chronic giardial infection. They excluded only by stool microscopy. We all know stool microscopy is not going to pick up 100% of giardia. You really need either duodenal aspirate, duodenal biopsy, or fecal antigen. I suspect in those studies from Norway who describe 80% patient with giardiasis as post-infectious IBS, they are confusing with chronic giardiasis, and the studies did not exclude it adequately. Therefore, that data has to be taken with a pinch of
So
salt.
therefore, post-infectious IBS can have a malabsorption component as well, right? Taken. So that's the summary of the first case. And as we've already mentioned, bacterial infection, protozoal infections are the predominant ones. Younger age, female gender, psychological stress, protozoal infections are the common ones. And management of these patients is as for IBS. Now, this is a second case which we also come across, a patient with ulcerative colitis who's actually in remission, who's on ASA preparation for proctosigmoiditis along with azathioprine. This particular patient has few triggers, but in addition has some lower abdominal discomfort. There's no blood or mucus, but there's, as usual, the patient says she has gas all over with increased flatulence. Clinical examination is non-contributory. Dr. Monica, what do you think now? This is an ulcerative colitis patient with lower GI symptoms, with some bloat, some gas. So are we dealing just with an IBD with a flare, or you think it's an IBD with any other component? Because both are stress
I think
related.
first time whenever a patient of IBD who was doing well and is coming with some symptoms, exacerbation of symptoms, we need to primarily check for the reactivation of IBD. But in addition, the patient can have some other problems also. The person can have two different problems coming at the same time. He may have associated IBS or some other dyspepsia. So first we have to rule out IBD, exacerbation.
So what will be your diagnosis, Dr. Piyush, at this juncture? Patient has ulcerative colitis, is fairly in remission, but she's still not happy, she's having discomfort.
In ulcerative colitis, the symptoms correlate very well. The stool frequency, urgency, and blood in stool correlates very well with mucosal healing. So, I mean, still if the patient is having persistent symptoms, I would look for inflammatory markers both in blood and stool, and then maybe just do a sigmoidoscopy. We do not need even to do a full-length colonoscopy to see whether the patient is in remission. The question comes with that, whether we need to prove histological remission in these situations. That is, I mean, there is no clear-cut answer on that, because we do not have the pathologist reporting it very well, and we do not always do it when we have a normal-looking mucosa.
Yeah, so in these patients, you think we should push in for thinking that it could be an aggravation, increase the immunomodulators, or you think we should have a little bit of some basic investigations and then proceed for evaluation? What's your take?
So, ma'am, in this patient, we'll go for a baseline C-reactive protein, fecal calprotectin, and sigmoidoscopy. I think that's
minimal,
good enough for going ahead with the further
investigation.
May I raise a point, ma'am?
Yeah.
If the colonoscopy appears normal, should we take biopsy? Because if we take biopsy from our persons in tropical country, we will find some degree of mild colitis. So whenever we take biopsy from normal colon, the report is at mild chronic inflammation. So in ulcerative colitis in remission also, they will say the same thing. Then how will we differentiate it? Any idea, Professor Ghoshal?
Fecal calprotectin may be helpful, I think.
I agree with both of you. First, my job will be to document that there is a complete control of IBD. So how to document complete control of IBD? One is fecal calprotectin, third is a colonoscopy and mucosal healing. The mucosal healing, as far as current standard is concerned, is Mayo grade 0 on colonoscopy. It does not necessitate you to show histological mucosal healing. In fact, histological mucosal healing may not always occur. If patient is symptomatic, now you apply Rome criteria. If Rome criteria is fulfilled, this is IBS in patient with IBD in remission. What is the frequency? As high as 30% patient with UC in remission has IBS in addition to IBD. And these patients have to be not only treated as IBD with usual therapy that is on, also treat like IBS with a standard therapy. Now, if the disease is not controlled, obviously you have to add up immunomodulator, immunosuppression.
Yeah, we just take up that. Dr. Neha, you have comments on this?
Yes,
Would you like to, what investigations?
That there is actually a studies which has shown that in patients with IBD who are in disease remission, when they have superimposed IBS, the levels of calprotectin may be higher as compared to those patients who are in complete clinical and endoscopic remission. So therefore, with IBS superimposed on active IBD, we will require to escalate the treatment. So colonoscopic and biopsies becomes important in these cases.
So I think the important thing
I'll
is,
share with you, we did a study recently, which is under peer review now. We took IBS in IBD, we took IBD in remission without IBS, and we took a common garden variety of IBS. And what we found is IBS in IBD has higher fecal calprotectin, as she said.
that's
But
expected.
this high is not as high as abnormal.
As in ulcerative colitis.
So it is like, if it is like 45 in IBS in patient with IBD without IBS, it is lower, maybe 20, whereas in IBS without any IBD, it is lowest.
Yeah, I think so.
Symptom severity is greater in patient with IBS, common garden variety, than IBD. And psychological markers are greater in common garden IBS, not IBD. So we are saying that inflammation may be major driver in IBS IBD, but this may be the major driver, psychological issues may be major driver
So I think
in common garden
fecal calprotectin should be a good marker to distinguish whether it
Do you
is.
think that rectal compliance and do these patients with IBD who are in remission with proctitis, does the rectal compliance actually come back to normal? Is rectal compliance playing a role here?
Yeah, that's why we are saying IBS-like symptom in IBD. You are talking about pathogenesis. Why do these patients have IBS-like symptom after IBD? That means maybe some degree of inflammation is still continuing, but not as bad in inflammation as severe IBD. They have increased serotonin in gut mucosa. There has been studies on that. They have muscular mucosa hypertrophy, and even Crohn's patient has some degree of submucosal fibrosis, so reduction in compliance. So this is the pathogenesis, and they have dysbiosis as well.
And sir, this side effect of 5-AS also includes diarrhea.
I did not hear.
Adverse effect of 5-AS also includes diarrhea.
Yeah, that's right. So that can
So
also be one explanation,
just come back to the patient.
but not major explanation given in the literature.
So basically, the ulcerative colitis with IBS combination will have the gut-brain axis also coming in. That's why they have this bloat and other things. So I think that's the treatment. Dr. Varghese, you would like to comment on the management of these patients? Should be managed differently for the IBS patients with IBD, or?
No. First, of course, we have to rule out activity by all means. Okay. So we should not be missing an active disease. Actually, there are not enough studies for the treatment of the IBS symptoms in ulcerative colitis in remission. So the standard therapies which people have done, like probiotics, fecal microbial transplantation, all have failed. So there is no role. And the only role has been with the tricyclic antidepressant, which we find also is useful in IBS diarrhea type. Well, if one can totally rule out mucosal inflammation, antidiarrheal and anticholinergics can be tried. But we do not have enough literature support to say any particular drug will be of definite use. It is mostly on symptomatic lines that we will be treating.
I think you have to be cautious in managing the IBS symptoms like loperamide and all. Anyone, would you like to comment on use of loperamide in patient with loose stool and has an IBD component to reduce the frequency?
You are asking me?
Anyone?
Yeah. So see, loperamide can be given provided there is no blood in the stool.
And no pain.
Blood is a red flag here, because loperamide can precipitate toxic megacolon in patient with IBD, which is of significant degree of exacerbation. Second is, if fecal calprotectin is high, I will not give loperamide. But I will give a serotonin blocker, because we know pathophysiologically serotonin is increased. If pain is a major factor, I will first try with a muscle relaxation at visceral level, which will include mebeverine, maybe pinavarium, maybe anticholinergic. And still, if it doesn't work, I'll add a visceral neuromodulator such as tricyclic antidepressant.
Yeah, small dose of TCA should help some of these patients. I think that's the only study which has shown some response in these patients. So basically, I think in any patient with IBD who is actually in remission but is not completely all right, you should consider the possibility of an IBS component in these patients, and most of them have a mixed or a diarrheal type. Constipation is uncommon, and TCA has probably some role in management of these patients. And as Dr. Uday had mentioned, to be careful with loperamide, it can be used. The third case and the last case, this is a lady who has long-standing 2 to 3 years of crampy lower abdominal pain, again with diarrhea. Started off with abdominal pain, followed by diarrhea. There's exhaustion and fatigue. There's abdominal bloat. Again, there are triggers. There is weight loss. And to circumvent all this thing, there's also a family history of IBD. And a person who was always active and working is now almost at home. Clinical examination was non-contributory and rectal examination was normal. So within a month of onset of symptoms, patient has had all these investigations, a stool examination, workup for celiac disease, non-contributory, there was screening for cancer, upper GI endoscopy and duodenal biopsy, ileocolonoscopy was normal. She was labeled as IBS diarrhea type, so she was asked to take a low FODMAP diet. CT enterography was also done, that was normal. Stool calprotectin was negative. Duodenal biopsy was also non-contributory. Dr. Neha, would you like to comment? What do you think you should do? What are we dealing with?
So, ma'am, seeing the history of this patient, we can understand that this seems to be more of an organic
Can speak
disease.
into the mic, yeah.
It seems to be more of an organic disease than a functional disorder. As the patient is losing weight, there are nocturnal episodes. She's symptomatic for the last 3 years. So we have done the basic test. My first suspicion would have been IBD in this patient, considering she has a family history, but we have done both endoscopy and biopsies, colonoscopies, all are normal. But there is one important disease which we have not tested so far in this patient, and that is microscopic colitis. So the next step that I would like to do in this patient is to do colonoscopy repeat and take biopsies both
that's
from the
important.
right and the left colon and check for the presence of microscopic colitis.
Dr. Uday, any comments? At this stage,
Yes.
at the clinical level, would you consider a functional or an organic disorder?
Yeah, I'll tell you, this functional and organic I don't really like. It is too much dichotomous. So what happens is, as she correctly said, there are features which suggest this may not be all non-organic. So what happens is, yes, what could be the condition which will lead to similar problem? One is, could she be having mild malabsorption syndrome? Second is, could there be bacterial overgrowth? Third is, could there be microscopic and collagenous colitis? The investigation that you have already done, all these do not rule out three entities: mild malabsorption, collagenous and microscopic colitis, and SIPO. So typically such patient, I will do a glucose hydrogen breath test, maybe upper gut aspirate culture, and I will do a colonic biopsy. And we know colonic biopsy must be done in this patient even in presence of normal.
Yeah, that's the take-home message. Even if the colon is normal, biopsy should be taken. And if you're suspecting microscopic colitis, biopsy should be taken, as Dr. Neha had mentioned, both in the ascending as well as the descending colon. So this is what happened. So actually the initial investigation, duodenal biopsy was taken for the celiac disease, but colonoscopy, since it was normal, which Dr. Uday mentioned, the biopsy was not taken. And so the patient went for a second opinion. Colonoscopy was done along with the biopsy this time, and she was started on budesonide. The bowel frequency now started coming down, the stool was formed, and she actually had a lymphocytic colitis. Dr. Varghese, you can just tell, we have the two types of colitis, microscopic. You can just tell the major differences in histology between these two.
Well, basically it is a pathologist area. They have to give us the clear diagnosis. In both conditions, there's a lymphoplasmacytic infiltration of the mucosa. So that is background thing. But in collagenous colitis, there will be a subepithelial collagenous band, which is more than 10 microns. So that is the typical finding.
You can see here, this is the man, this is the collagenous.
In the case of lymphocytic colitis, the intraepithelial cells will be more than 20 per 100 epithelial cells. So these are the two essential differences. So there could be some derangement of the epithelium, which are not specific, and there will be background inflammation with the lymphoplasmacytic cells.
So I think the important message is you can have these two types of colitis, a collagenous and lymphocytic. Both are histological diagnosis. And here you find there's this band of collagen that's very classical of collagenous, whereas intraepithelial lymphocytes is more classical of lymphocytic colitis. So it is an important differential diagnosis of IBS. I still remember in one of the national board examinations, this lady she had diarrhea for 20 years, and the examiners were waiting for a DD of a microscopic colitis. So it is more common in women, and the female to male ratio is 9:1. As in the two colitis that we described, this is another colitis where the pathogenic mechanism is just the same. You have the genetic component, the gut microbial diversity, and then you have the leakage of the mucosa, you have the cytokine response, and the visceral hypersensitivity. So it remains the same. So when you suspect microscopic colitis, any patient coming with intermittent symptoms of non-bloody watery diarrhea. But just remember, in the present days, we have these sartans causing diarrhea, we have metformin causing diarrhea, but this was a 7-year history of diarrhea, so history of drugs is important. In addition to this, you have the urgency, fecal incontinence, discomfort, weight loss, arthralgia, almost all the symptoms that can occur in a stress-related person with an IBS. And onset is often insidious. It can be sudden in 25%. And as Dr. Uday had mentioned, look at the number of differentials here. You can have an IBS, it can behave like an IBD because of crampy abdominal pain. They can have a celiac disease like component bile acid, Dr. Piyush had mentioned, lactose malabsorption, and SIBO. So in a patient with chronic diarrhea, presenting with long-standing crampy abdominal pain with watery diarrhea, while microscopic colitis comes as an important DD, in the presence of malabsorption, you have to consider some of these small bowel pathologies. So how do we proceed for evaluation, Dr. Piyush? We've already discussed most of it, but you can just tell.
Yeah. So the basic message is that in a person where you suspect...
And how to manage, basically, investigation management.
So here, once we have diagnosed the first line treatment is budesonide. We start with budesonide, and the patients who respond and do not relapse subsequently do not require anything, and patients who relapse after a 8-week course, then they can be offered a maintenance therapy at a lower dose. And in patients who do not respond, we should evaluate them for alternate diagnosis, or then there are difficult choices of like using methotrexate, azathioprine, or biological TNF blockers.
Yeah, I've seen just probably one patient. Any of you have experience with this type of, anyone in the audience who has an experienced microscopic colitis and who have used biologics or immune checkpoint inhibitors? Anyone can comment on this? Because for me, this was news while I was preparing this, that in severe forms of microscopic colitis, there's a definite role for these immune modulators.
Yeah, you see, David Rubin, who is an authority on IBD, says microscopic colitis is nothing but a form of IBD.
It's a form of?
We have seen microscopic colitis patient, but most patients responded to the first line budesonide, or at most we have to give azathioprine. I have never used biological in this patient. Their disease severity is much lesser in my experience than usual common garden IBD.
Dr. Neha?
They respond beautifully to budesonide, that even oral prednisolone and visolone are not indicated for use in these patients. So it's very rarely that they need to go on immune checkpoint inhibitors, and the surgery, whatever case reports of surgery are there, they were practically of those times when budesonide was not available. So in more than 99% of the cases, they respond only to budesonide.
So I think, there's not much of literature on the use of biologics in these patients. Anyone in the audience, if they have any experience with microscopic colitis, can just come forward and discuss. So the key message in this third case is microscopic colitis is an important differential diagnosis in any patient who comes with unexplained watery diarrhea, chronic watery diarrhea. Remember the important differentials, which includes an inflammatory bowel disease. Most important is the colon will appear normal, as in a patient with ulcerative colitis who is in subclinical or in clinical remission. Colonic biopsy, as Dr. Neha had mentioned, ascending and descending colon biopsy is absolutely important. Classical findings of collagenous and lymphocytic colitis we have just discussed. Age of presentation in majority of the patients is above the age of 50. And in 25%, it can occur in less than 40 years, as in our patient. It's common in women. And there are some literature reports on increase of risk of lung cancer and lymphoma. I think we have discussed 3 important cases, and I have about 5 minutes left for any questions which can be posed to the panelists and some experience that can be shared with us.
Ma'am,
Now,
in
you
the
now-
patient with chronic watery diarrhea, like this case, we are going to diagnose microscopic colitis and going to give steroids. Is it possible that an immunocompetent person may be having cryptosporidiosis community acquired, and ordinary stool examination will miss it completely? So unless we specifically look for cryptosporidiosis,
Only thing
we
is
can
the
completely
history,
miss it, no?
the cryptosporidiosis presents more like a choleric diarrhea, which should be short history. You will not have a 7-year history of abdominal pain. No, so the person will be, I've seen one patient with cryptosporidiosis, they have malabsorption and they present like choleric diarrhea. So in this context, maybe drugs is important, sartans, metformin, and these are the important ones.
You raise an important point, but when I was in public sector, I will do all investigation because it was cheap. Now try to understand, if you find malabsorption, so you have to find malabsorption. How to find malabsorption? Do a D-xylose test and fecal fat test. Many will say, I can't do D-xylose test. Those who have a hydrogen breath test machine, do D-xylose hydrogen breath test. Is as good as D-xylose test. So now, once you find malabsorption, you can check for this cryptosporidia, isospora and all those. That is one. So D-xylose will become a screening test first. Second is that for opportunistic pathogen, you ask your microbiologist to do a modified acid fast stain and it will pick up. Like we say, do a routine stool microscopy, hematoxylin eosin staining, as well as a modified acid fast stain.
Any questions from the audience? I think I'll thank my panelists. They've done a wonderful job. Thank you, Dr. Deha, Dr. Monica, Dr. Uday, and Dr. Piyush, and Dr. Varghese. I troubled them a lot with the presentation, and thank you very much. Thank you.
Thank you, ma'am.
Thank you. I need help. Can you ask someone to come and help me to come down the steps, I said. So please come up and announce.
Before we move ahead, I would like to present a small AV on inception and journey of INMA iPhorum. The previous session was really wonderful. Thank you all the panelists and our discussant. Now moving forward to iForum case 3, case of dysphagia. Inviting our panelists Dr. Saransh Jain, Dr. Vikas Singla, Dr. Nitin Jagtap, Dr. Nitesh Pratap, Dr. Ashok Dalal on stage, and our discussant Dr. Akash Mathur.
A very good afternoon to one and all. I sincerely welcome all the panelists on the stage. So as we have just seen that the purpose of iForum is to take all the physicians on board and develop a standardized approach to various disorders of GI motility. I'll be presenting a case of dysphagia, and with the help of our experts here, during the course of this presentation, we would try and develop a algorithmic approach to patients presenting with dysphagia. So here we have a 40-year-old female who presented to us with progressive difficulty in swallowing, that is dysphagia, over the last 12 months. Dysphagia was for both solids and liquids since the beginning. She also experienced frequent heartburn and acid reflux. There were also episodes of chest discomfort, which were often mistaken for cardiac issues, and she had to visit the emergency department of the hospital frequently for those. She had an unintentional weight loss of 5 kgs during the duration of this illness. Now, coming to the difficulty in swallowing, it was gradual in onset, progressively increasing for the last 1 year. As I mentioned, it was for both solids and liquids since the outset. Initially, it occurred only 3 to 4 times per week, but subsequently, now it is occurring with each meal for the last 4 months. The patient reports experiencing persistent heartburn, especially after meals. There were also intermittent, non-exertional chest discomfort episodes, which were predominantly burning in nature, and occasionally this chest burning radiated to the back as well. These episodes often coincided with meals. However, the patient did not report any significant regurgitation of food. Coming to the negative history, there was no history of difficulty in initiating the swallow, no association with nasal intonation of voice, dysarthria, diplopia, or dysphonia. Patient did not report any hoarseness of voice, sore throat, coughing, wheezing, or recurrent chest infections. History of frequent falls, difficulty climbing stairs, or lifting heavy objects was also not elicited. There was no complaint of muscle twitches or fasciculation, and the patient did not report any progressive weakness of articulability or drooping of eyelid with activity. Also, there was no history of head and neck radiation, no personal or family history of thyroid issues like goiter, no previous history of inflammatory bowel disease or celiac disease. Patient denied any prolonged intubation, esophageal or head and neck surgery, or ingestion of caustic materials. There was no history of atopy or allergy. No preceding use of chemotherapy or diagnosis of an immunocompromised state. Patient denied having any recurrent pneumonia or chest infections. She although had a past history of appendicectomy 5 years ago. So now I would like to come to our panel for discussion based on the history. So first of all, I would like to come to Dr. Saransh Jain, sir. So, sir, how do we differentiate between oropharyngeal and esophageal causes of dysphagia?
Thank you. Are you able to hear me? Yeah. So to differentiate between oropharyngeal and esophageal causes of dysphagia, both of them will work as dysphagia to both solids and liquid. But when we look at the oropharyngeal causes, they will have difficulty in initiating the swallows. They will also have difficulty in change in voice, hoarseness of voice, may have history of diplopia, or history of aspiration pneumonia, or history of recurrent aspirations. These factors in history can help us differentiate between oropharyngeal and esophageal causes of dysphagia.
Sir, sometimes does it also help asking the patients a leading question about the timeline? Like, does he have, during the initial 2 seconds, 3 seconds, can we give him a period that when does he have this dysphagia? During the initial 2 seconds or afterwards? So, such a leading question can be asked.
Usually patient themselves come out with the fact that, sir, there is this change in voice, he is not speaking the way he used to speak. And as soon as he takes something in his mouth, he spits it out. So that.
Okay. So, Coming to Dr. Vikas Singla, sir. Sir, how do the onset and progression of dysphagia symptoms guide our diagnostic process?
Whenever we have a patient with dysphagia, it can be either a mechanical dysphagia or it can be a motor dysphagia. In mechanical, it can be then either a benign or a malignant cause. So, if since the beginning patient has dysphagia only for solids and it's rapidly progressive, and later on patient developing dysphagia for liquids also, solid to begin with and liquid later on, it's likely to be a mechanical dysphagia, and in elderly patient with the weight loss, it's likely to be malignant. On the other hand, in case of benign disease like peptic stricture, there is a non-progressive dysphagia, and most of the time patient come with the history of bolus impaction in case of peptic stricture. Then coming to the motor dysphasia, where atlesia is prototype. So here patient can have either dysphagia mainly for solids, or to begin with patient can have dysphagia for both liquid and solid both. And there can be progression in this also, but it's the progression is less severe in case of motor dysphagia. And similarly, weight loss will be less in case of a motor dysphagia as compared to a malignant dysphagia.
Okay. Coming to Dr. Nitin Jagtap, sir, what is the importance of asking about extraesophageal symptoms in history? Like often when we evaluate a patient of dysphagia, our major focus is to identify and talk to him about symptoms pertaining to the esophageal disorders only. And so how does it impact the extraesophageal symptoms in history?
So, knowing about extraesophageal symptoms in the patients presenting with dysphagia is very important to rule out whether patient is having native esophageal disease or there is something else occurring at multisystem level. Some diseases such as neurological diseases can present with muscular weakness, ptosis, or there can be a fatigability. These symptoms can indicate neurological causes. There are few diseases which are mixed connective tissue disorders where you will find symptoms related to skin, joints, etc. For that, we need to ask for extraesophageal symptoms.
Nitesh Pratap, sir, we would like to know from your expertise that can you please summarize for us what are the differences between mechanical and motor dysphagia?
As Dr. Singla has already told, that mechanical patients will mainly present with initially dysphagia for solids, and basically then it will be for liquid. But in patients with motor dysphagia, it will be both for solids and liquids. And even for, as is told, the duration. Suppose if it's a malignancy, it will be a very rapid progression, fast progression when compared to any person with eclasia. What we see, and the weight loss will be will be more in these patients. So mainly if it is only for sequential, first for solids followed by liquids, we'll think more of mechanical, and in motor it will be for both.
Okay. So with that, I would like to come to Ashok Dalal sir and ask what are the differential diagnoses you would like to consider in this case.
Now, this patient has started is dysphagia since the beginning to both solids and liquids. So this makes the diagnosis a little bit easier that this is likely a neuromuscular disease that is causing the dysphagia. So it can be primary disease, eclasia, esophageal gastric junction outlet obstruction, or but the unusual history was that there was reflex symptoms and heartburns. So usually we don't see that in more in eclasia, but that is there in reflex esophagitis or scleroderma. So that also has to be kept in mind. These patients in later stage when you have continuous reflux symptoms or these things can develop peptic stricture also, because she has severe dysphagia in the later half of this thing, or can develop even malignancy also at that point of time. So all these things have to be kept in the mind.
Sir, so these symptoms predominantly look like motor symptoms more, but can at the point of history itself, can we absolutely rule out any mechanical obstruction or lower down the list, but that has to be kept in our mind?
It's better to keep in the mind in this case.
Okay. So moving on examination, this patient had a BMI of 19.1 kg per meter square. She had a pulse rate of 86 per minute with a blood pressure of 110 by 70 millimeter of mercury. The respiratory system showed bilateral equal air entry with no adventitious sounds. The cardiac and the abdominal examination and the CNS examination was non-contributory. She had mild pallor, but no significant pedal edema or lymphadenopathy. However, there was notable skin thickening and hardening, particularly on the hands and face. We could also elicit Raynaud's phenomena, which was observed in the fingers with pallor, cyanosis, and erythema upon exposure to the cold. So, sir, does our differential diagnosis change after examination? Dr. Saransh Chen and then other
So
panelists,
after
please.
examination, we are also finding some systemic finding in this patient. So patient has notably sclerodactyly and Raynaud's phenomena with pallor. So with these findings, the order of the differential diagnosis I would like to change and now like to keep connective tissue disorders such as scleroderma on higher priority, then localized esophageal disorders like atlasia cardia or esophageal gastric junction obturator obstruction.
So coming to Dr. Vikas Singla, sir.
Yeah, I agree with Saransh. With the history, it appears that patient has likely motor dysphasia. So either it can be atlasia cardia or it can be scleroderma. And after the examination, I think the diagnosis nearly confirmed. It's a scleroderma with the esophageal dysmotility.
Okay, and Dr. Nitin Jagtap, sir.
There is no more comment
So,
from my side, but once we find something solid on the systemic examination, the next question is how do you proceed rather than like sclerodactyly thickening of skin that almost sine qua non of scleroderma. So
Sir,
we need to further move on to how to evaluate this patient.
Sir, before we move on, just one important point which I wanted to discuss was that what are the important examination points that one needs to remember while approaching a case of dysphagia? Because often it is the thought of that in a case of dysphagia, it will be the investigations which would reveal more rather than the systemic examination. So, are there any specific pointers or specific systems or specific things which we need to look for in the systemic examination while evaluating a patient with dysphagia?
Lymphadenopathy, thyroid examination, pallor you have to look for specifically. The neurological examination should be done properly to look for any muscle weakness or any neurological weakness and gait changes. So these examinations are important before we proceed into investigation in such a case.
So moving on to Dr. Nitesh Pratap, sir.
Yeah.
Very important is ask the patient to eat or drink in front of you, because this is vital part of the examination. I typically ask the patient, do you have a water with you? Says yes. Can you drink in front of me and let me see what is happening? This is very critical.
Thank you, sir, for those pearls of wisdom.
I would like to add in this thing. In most of the patient of oropharyngeal dysphagia, they will have coughing reflex while drinking those water. So asking the patient, this is a common practice which I also follow, to drink in front of you, you will come to know whether it is a oropharyngeal or esophageal cause of dysphagia. So in Hindi, we would say dhaska lagta hai. So that typically the word that come out, the patient will start coughing while taking water.
So how to further investigate this patient, Dr. Nitesh Pratap, sir?
Basically, I think basic blood test followed by an upper GI endoscopy, and if it is normal esophageal manometry, this will be my order of investigation.
Dr. Ashok Dalal, sir?
Yes, like sir said, upper GI endoscopy that will show whether how severe were the reflux symptoms, if they are, how is the LES tone, you can measure. Okay, manometry will confirm those findings. A barium esophagogram will also give whether it's a lax LES or a very tight LES. That will also do.
I think to the blood test, we can also add autoantibodies, ANA and anti-SCL70, because we are suspecting scleroderma here.
So while we are at it, I would also like to ask that a lot of these patients, like as gastroenterologists, we would directly be approaching this patient with the endoscopy first. But a lot of these patients, they present to community physicians and clinicians. So what should be the approach, barium first or endoscopy first?
Yes. If you are not, endoscopy is not available, better to go for a barium first. And
So I think
then
in a patient with dysphagia, endoscopy should be first investigation. Because if endoscopy is normal or we are suspecting motor dysphagia, then we should go with the barium.
So moving ahead with the investigations in this patient, she had a hemoglobin of 8.1 grams per deciliter, a TLC of 12,000 with normal platelet count. Her ESR and CRP levels were high. She had a normal creatinine. However, her anti-nuclear antibody was positive with a speckled pattern, and anti-SCL70 antibody was also positive. The liver function test was essentially normal except for the low albumin level, which was 2.9 grams per deciliter, likely due to malnutrition in this case. Other blood workup was non-contributory. So we went ahead and did an upper GI endoscopy in this patient and found a dilated esophagus, particularly in the distal part, with few mucosal breaks at the G junction and reduced tone of the lower esophageal sphincter. A barium swallow done elsewhere showed delayed barium transit, a esophageal dilatation with barium retention, and a wide open lower esophageal sphincter. A higher resolution manometry done showed absent peristalsis and lower esophageal sphincter hypotension. Which brings to our next point of discussion. What do you do in patients with dysphagia, a barium swallow or a timed barium esophagogram? Which one is better and which is to be done? Dr. Saransh Chand, then Dr. Nitesh Pratap and Dr. Ashok Dalal.
So, when we talk about barium swallow, it is a test which is done for both structural and the function of the esophagus. Whereas time barium swallow is a specific test for esophageal emptying. When we are having a suspicion of motor dysphagia, then the time barium esophagogram is a better test than a barium swallow.
Yeah, I agree with you. I think the most important, if you are suspecting delay in emptying, you should do a time barium.
Okay. And coming to Dr. Vikas Singla, sir, when do a computed tomography, CT scan of the chest, when do we do it while evaluating a patient with dysphagia?
So if I think first test should be endoscopy. Sometime on endoscopy, we don't see any sign of malignancy, but there is a tight resistance at the G junction. That time it can be a pseudoachalasia. There can be a tumor at the G junction. So especially in elderly patient. So in achalasia, cardia scope will always pass down. Even if there is obstructions, you will be able to go down the narrowing. But in pseudoachalasia or malignancy at G junction, there can be tight fixed obstruction where you may not see a mass lesion, but your scope will not be possible sometimes. So in these patients, either you can do same setting endoscopic ultrasound or you can do CT scan to rule out malignancy. Or if you are finding a stricture in the esophagus and irregular stricture, we should do a CT scan for further evaluation.
Dr. Ashok Dalal, sir, are there any clinical pointers also which help us guide or identify pseudoachalasia early? As sir said that wherever we are suspecting pseudoachalasia, we would like to go for a CT. So are there any clinical pointers in the history which we can take to for suspect pseudoachalasia?
Like patient is a chronic smoker, is more likely to have malignancy. Patient is an elderly patient, or patient have a profound weight loss. These are the subtle indicator which we can see on history. Yes, this patient you can suspect a malignancy, and you better go with the CT scan to rule out those symptoms.
Okay. And the next thing we have already discussed, I think, when is endoscopy indicated? I think in all patients, endoscopy versus barium first we have already discussed. So this is something that I wanted to apprise our audience with, timed barium esophagogram. In almost all our settings in the clinical practice, we have radiologists perform barium swallow. But with some help from us, I think we can all transform those barium swallows to timed barium esophagogram, which is the standard of care for patients with suspected motor disorders of the esophagus. So it has to be a single swallow, fixed volume and specific density of barium suspension, which is usually 45% weight by volume. Erect posture during entire study. Left posterior oblique films are to be taken at 1, 2 and 5 minutes. Orally ingestion should be done within 15 to 20 seconds. Volume should be between 100 to 250 ml, but should be fixed for one patient. And barium should completely empty from the esophagus in 1 minute in most and in 5 minutes in all healthy individuals. For the diagnosis of achalasia, barium column height more than 5 centimeter at 1 minute and more than 2 centimeter at 5 minutes are suggestive of achalasia. Even while evaluating response to therapy, we have to take care that we have to give the same amount of barium that we had given prior to therapy in patients with achalasia or other disorders. So after our blood workup and the diagnostic modalities, I think the diagnosis is pretty clear that this is a case of esophageal dysmotility secondary to scleroderma. So coming to the management part, Dr. Nitesh Pratap sir, what are the medical treatments available for patients with dysphagia?
For a patient like this with scleroderma, with esophagitis, I think first one is proton pump inhibitors, and those with associated gastric problem, you should add a prokinetics, because there have been studies in patients with scleroderma, because they have shown that if you only start them on PPIs, almost 40% do not have good response to therapy. And there is one study which has shown that if you add a prokinetic with the allogeneic, they have a better response. So it's mainly PPI, prokinetics, and dietary modifications. This is what I feel.
I would like to ask Dr. Nitin Chakta sir here that in cases, like in this case, it would be medical management first, but in cases of achalasia and other disorders, esophageal motility, does medical management have a role there also?
So for other motility disorders such as achalasia, we have a endoscopic therapy and surgical therapies. And now the current literature is showing that endoscopic therapy, particularly per oral endoscopic myotomy, is giving good and good results with less chance of having reflux esophagitis also. So endoscopic therapy can be considered for the patients who are having achalasia and other motility disorders.
Okay. And for those patients who have ineffective esophageal motility, can medical management have a role there as well?
The patients who are having ineffective motility, I believe there is no appropriate medical therapy available, but we can try prokinetic and modification of diet.
So GERD sometimes increases ineffective esophageal motility. So we have to rule out GERD. If GERD is present, we can add them on proton pump inhibitor. So per se, ineffective esophageal motility does not have a medical treatment, but GERD associated with it might help it resolve.
So what role does nutritional support play in the management of dysphagia, Dr. Ashok Dalal sir?
Nutrition is the key role in any chronic disease. Now, if patient is not able to eat, that is the biggest problem. So in this patient, especially, anyway, we are not correcting mortality. We don't have anything to correct mortality. So we'll ask the patient to take some small meals, sit upright most of the time after taking meal, so that by gravity the food goes into the stomach. She has anemia, she has low albumin, so we have to correct that. Many of these scleroderma patients may have telangiectasia or microhemorrhages from which blood loss might be occurring. So you like to substitute iron in these patients, but giving oral iron may accelerate the symptoms of reflux. So better to give IV iron, high calorie, high protein food shall be given. Initial stages, stomach is not involved, but in later stages, sometimes stomach can also be involved. Then you can do a PEG-J or jejunostomy to start the feeding of these patients if the case is very severe. But adequate calorie count and protein should be given to the patients so that they can maintain their nutritional status.
So what endoscopic, therapeutic and surgical options are available for dysphagia and when are they indicated? Dr. Saransh Chen, please.
So when we talk about surgical options are mostly limited to mechanical dysphagia. If you have a stricture, malignancy, you would like to go for surgical curative or a palliative treatment. When we talk about motor dysphagia, in achalasia cardia, Heller's myotomy is a good indication for type 1 and type 2 achalasia. Type 3 achalasia, POEM does better than Heller's myotomy. When we talk about reflux increasing dysphagia, in some cases like ineffective esophageal motility, if they don't respond to medical treatment, then they can be subjected to fundoplication. This is probably the main surgical options that we have for dysphagia.
Dr. Vikas Singh, sir.
Sometimes we have patient with the corrosive stricture. They have a long segment stricture. So they may not improve with the endoscopic dilatation. In this patient, gastric pull-up, I think, can be offered for the relief.
So With this, in this patient, the general measures were taken like small frequent meals, elevating the head end of the bed, avoiding trigger foods like spicy foods, caffeine, alcohol, and chocolate. She was started on high dose proton pump inhibitors therapy with prokinetic agents and added H2 receptor antagonists at bedtime. And treatment for underlying scleroderma with immunosuppressive therapies was started. So I think now we can ask all the panelists, how do you follow up these patients and what follow-up strategies would you recommend for patient with dysphagia? Dr. Saransh first, maybe.
So when we talk about follow-up strategies, we have to see what type of initial dysphagia we are dealing with. If it is a neuromuscular dysphagia, we have to focus on the neuromuscular aspect of it to get it treated. If it is structural dysphagia, we have to look for the treatment options that we have done and follow up according to the recurrence of symptoms or as and when you feel that the next dilatation is required. When you talk about motor dysphagia, when we are dealing with achalasia cardia, usually when we do an endoscopic or a surgical treatment for achalasia cardia, we like to follow them up monthly for a few months and then 6 monthly and yearly. So this is how I follow up my patients for dysphagia.
Okay, and sir, yes, please.
Like as he told, it has to be etiology wise. Like if, like say, mechanical obstruction, definitely. If you have taken good care of obstruction, like if it is a patient of esophageal carcinoma, you have done surgery or something, that patient is okay, then it's means followed by the oncologist basically. For in our case, like we are following mainly after the neuromuscular, like achalasia patient. You ask the patient to monitor the ECCARD score. Okay, whenever the ECCARD score is increasing, then you have to repeat the investigations for any recurrence, etc. In this patient, scleroderma patient, here we are not changing the basic pathophysiology. The problem is persisting. We are just managing the symptoms better. So in this case, nutrition has to be followed up regularly, how the patient is able to take food also or not, how the disease is progressing. Initially, it may be in distal esophagus, next it may be in stomach and come to duodenum also. So you have to continue follow up the patient and plan his nutrition or her nutrition accordingly.
Nitesh Pratap, sir.
Actually, one comment I wanted that in patients with scleroderma, other thing you have to be very important is in follow-up, you have to look for any lung involvement because that is one of the very important thing because it has been shown that if the early lung signs in these patients, better to do a pH and impedance, and if you are able to show, you have to be very aggressive with the anti-reflux to prevent long-term problems to the lung. So that is one indication where you do pH in these patients.
Okay, sir, and
so additionally, scleroderma patient, they can develop small intestinal bacterial overgrowth. They are prone for malabsorptions and constipation also. So we need to see out these symptoms also, whether they are managed appropriately or not, and how the immunosuppression, after immunosuppression, what's the symptoms level, then we can decide further treatment and strategies.
So this patient had issues of heartburn, dysphagia, and weight loss. So first, I think with the PPI, we'll look for whether there is good control of heartburn or not. Then for dysphagia, we can calculate the dysphagia score on follow-up, and we should maintain the adequate nutrition. We should have a good calorie count for the patient, whether the patient taking adequate calorie or not. If the calorie intake is poor, then we have to look for either placing a tube, a PEG tube or the NG tube. And we should also have a weight chart also. The patient should gain weight on follow-up. And this patient actually had GERD also, so these patients are prone to Barrett and adenocarcinoma also. That should also be kept in mind during follow-up.
okay. So that sir, does being prone to Barrett's makes us rectify our follow-up strategy and do surveillance endoscopies also?
So it's difficult to say, but I think at least if the patient has symptom for 10 years, we should offer them endoscopy once in 10 years to look for the Barrett esophagus.
And another thing that I wanted to ask is that in our busy clinical practice, we often do not use a lot of disease activity scores. So does they have a role in management of patients with dysphagia, like activity scores like ECCARD? Should we regularly use them? And are there any such scores which we can use for other disorders, other motility disorders apart from achalasia?
So CAR-T, I think, is used more in the clinical trials, but I think in the OPD, it's very easy to make out whether patient is having symptoms or not. Mostly after treatment of CAR-T is meant for achalasia only, basically. So most of the time, patients improve after the either poem, Heller, or balloon. And even if they relapse, the score is mostly 2 or 3 only. No patient will have the full-blown symptom after the treatment. So they come back with the complaint of occasional dysphagia. So the maximum score, the card score will be again less than 3 also.
So the take-home message now, it is important to identify dysphagia symptoms early, including difficulties in swallowing, choking, or the sensation of food sticking in the throat or chest. Gather a detailed patient history, assess the duration, onset, and progression of symptoms, and inquire about associated conditions such as weight loss, regurgitation, or heartburn. Differentiate between oropharyngeal dysphagia and esophageal dysphagia. Investigations like barium swallow, endoscopy, esophageal manometry are helpful in diagnosis. The treatment consists of general measures, nutritional support, specific medical management, and endoscopic intervention or surgery wherever indicated. Now, this is the algorithm while diagnosing a patient of esophageal dysphagia. We have to see whether the dysphagia is for solids only or for both solids and liquids at the outset. If it is for solids only, then it is probably structural. We have to see whether it is progressive or intermittent. If progressive, with slow progression, chronic heartburn, it points more towards strictures and esophagitis. With the rapid progression and weight loss, it points more towards a malignancy. If the symptoms are intermittent, then esophageal ring, VAB, or eosinophilic esophagitis is more likely. When the symptoms are both for solids and liquids at the outset, it is probably due to dysmotility. If the symptoms are progressive and have chronic heartburn as a predominant symptom like that in our case, then scleroderma or absent contractility is a more likely diagnosis. While if regurgitation is a predominant symptom, then achalasia is a more likely diagnosis. If the symptoms are intermittent, especially associated with chest pain, then we should evaluate for distal esophageal spasm. Thank you. So I think now we can open the house for questions from our esteemed panelists.
Very elaborative discussion. Sometimes our neurology friends send us patient who are suffering from post-stroke or dementia patients or myasthenia gravis, this like a patient, developed oropharyngeal dysphagia. So how to tackle those difficult patients and what are the management guidelines I want to know from the panelist.
I think even in these patients, first of all, esophageal causes should be ruled out. Additional esophageal causes should be ruled out. And again, we should, from our side, we should do an endoscopy to rule out any cause lower down in the esophagus. So I think the treatment of dysphagia depend on the underlying treatment of nasal disease. And till the time patient improve, we can give them additional support with placing either a nasogastric, nasogenital tube or going with the PEG.
So, very nice presentation. In this particular case, what happens once you treat scleroderma? I mean, if there is no stricture, if it is just motility disorder, then does immunosuppressive therapy, steroids, mycophenolate, whatever we use, does that lead to improvement of dysphagia if there is no stricture? And what is the result of dilatation once these patients develop stricture? How do they do? Do they fare like peptic strictures, or the result is not as good?
I think with the stricture, once we dilate stricture, the improvement may not be that good because there is no contraction in the esophageal body. In peptic stricture, we have a normal contraction in esophageal body, but here we have a different situation. There is a stricture lower down and the esophageal contraction are weak. Even if we dilate the stricture, we may not expect that much of improvement after stricture dilatation.
And medical therapy, I mean, if there is no stricture, then in patients with scleroderma, if they just have dysphagia because of motility, does medical therapy help?
I don't have personal experience of treating these patients, but I think when they come to us, mostly they have developed fibrosis in the esophagus. So it's more of irreversible condition.
So the motility will not come back, sir.
It's already fibrosis has settled.
Medical therapy may prevent the further progression of this. The other smooth muscles of stomach, they may not be, the progression may be delayed. But
but medical therapy won't delay the progressions. It won't.
So any more questions? So I think if there are no more questions, we can close the session.
Hello. Akash, we have time actually.
Yeah, one question.
So
We have
I
one
wanted
question.
to make a comment on the medical therapy part. Last question was asked. So we must understand that scleroderma esophageal manifestation is one of the manifestation of multiple manifestation of scleroderma. You won't expect a PPI to heal scleroderma or its esophageal manifestation. The hit has to be on the basic aspects of pathophysiology. Only thing is we can have symptomatic relief by the time the patient is taking PPI.
That is what I was
That
asking.
is
The
only thing
response,
that can help.
of steroid or mycophenolate, whatever immunosuppression
Will be there. PPI won't do anything except for symptomatic
PPI
relief.
obviously won't give a symptomatic relief. The question is about immunomodulator or immunosuppressive therapy.
So even then the disease symptoms appear when the disease has far advanced. So this patient came in years later. So this is why he told in the last slide, pick them up early.
So sometimes there very many patient comes who come with upper esophageal dysphagia and they've got one-sided vocal cord paralysis of one side and upper esophageal dysphagia. How best to treat them?
What you told is basically again oropharyngeal dysphagia. As sir has already told in the first question, you have to treat the basic cause. It is most likely the some neurological cause that is causing this thing. So till then, you have to give support for the nutrition. You place a PEG tube into the stomach, maintain the nutrition of the patient, and evaluate the cause that has caused this vocal paresy and oropharyngeal dysphagia, and then treat accordingly. Most of the neurological cause like stroke, etc., some kind of function may come back. Like patient may have some 80% relief, though some may take something orally over a period of time, 3 months, 6 months. So you have to wait till that time. Or in some patient they may not come back also.
I think such patient malignancy should also be ruled out. Unilateral vocal cord palsy dysphasia. A recurrent engine nerve can be involved, and we should do a CT scan to rule out malignancy in the chest.
Not related to this patient, but I will give you one option for therapy. Those patients who have ineffective esophageal motility disorder, not due to scleroderma, so there pyridostigmine help. And in fact, if you look at the literature, there are studies, small studies, both case series and some controlled trial, which shows pyridostigmine help. So these patients, I sometimes give pyridostigmine and find good result.
So, sir, any role of pH impedance study while evaluating a patient with dysphagia?
I told you that in these patients, especially when you are having an early lung involvement, those are the patients. Otherwise, if you are doing an endoscopy, they are already erosive and all. For diagnosis, you won't require it.
So, any more questions?
Have you
Okay, can I
have you been using prucalopride?
We have patient with dysphagia localized to the throat region, and we have a suspicion of a cricopharyngeal bar, but without any Janker diverticulum. If there is a Janker diverticulum, you can easily diagnose it's a cricopharyngeal bar with the secondary diverticulum. But if there is a bar only without any diverticulum, so can you diagnose cricopharyngeal bar by any other means? So, do the manometry will help in such cases?
Manometry will help, definitely. Upper esophageal sphincter manometry will help.
Okay, so do we have the value standardized for the upper esophageal sphincter also?
Kushal sir? Sir, have you ever used prucalopride for IEM?
Good point. You see, there are studies on this prokinetic. Like I remember Yantek from Belgium did a study using tegaserod, and what he showed is peristaltic vigor increases. Therefore, prucalopride, though mainly a lower GI prokinetic, have effect in the esophagus. Tegaserod has, etopride has, and there are studies on this.
Ecosiamide is also useful, sir.
Ecosiamide has been shown to work in the stomach as well as some degree of effect in esophagus and antroduodenal motility.
So I think while we are at prokinetics, I would also like to bring to discussion, like in such a case, which prokinetic to choose? We have a lot of prokinetics, and I think we can have a view from the panel and then from Ghoshal sir as well, that there are a lot of prokinetics, different mechanism of actions, which one to use? Because often in clinical practice, we have patient referrals where people are using two prokinetics with same mechanism of action. So which one to use?
So there are two type of scenarios. One is the postprandial fullness. The patient take meal and there is immediate fullness in the stomach. I think that is due to the poor accommodation of the stomach, fundus part. In that, one acoshamide can be attempted or the metazapine can be attempted. And if the patient has gastroparesis and more vomiting symptom, in those patients, I think domperidone can be helpful, or the citalopram can be helpful in those cases.
See, I think the most important thing with the use of prokinetics is I think we use a lot of domperidone, we use etopride, citalopram, serastole, prucalopride. I think amongst this you have to look at few things that if the patient is having cardiac issues and all, especially multiple, I think you should be very careful with the use of domperidone, especially with QTC prolongation. That is a very important thing. And I think etopride is having an effect, so I will prefer that in these patients.
And does the patient profile also affects the choice, like elderly age group or these things?
Yeah, basically if patient is elderly, then in that group, especially prokinetics like levosulpiride, I'll be a bit cautious of using because of the lot of extrapyramidal symptoms I see. Parkinson is a thing, motility, movement problem. So I'll be a little cautious in, especially in those patients.
Ghoshal sir, any views on the choice of prokinetic? Which one we should use?
I think most of the things have been discussed, but very important is always get an ECG before starting, particularly if their patient is elderly and comorbidity. Do not exceed the dose. For example, for prucalopride, not more than 2 milligram. For domperidone, not more than 30 milligram. Now, if one prokinetic is not working, when you are choosing another, always see that the mechanism is different. For example, if you are giving domperidone, obviously it is mediated through dopamine action. You give something else, for example, etopride, which is largely to serotonin or particularly prucalopride to serotonin. And then very important is that the patient takes the drug in appropriate time, for example, before meal. And during follow-up, I would like to repeat ECG for safety.
So one thing, so many prescriptions carry two prokinetics from different groups. Is it scientifically
No. You
tenable?
see, I also use sometime when one prokinetic is not working. But always I add two with different mechanism of action. And when you are giving prokinetics, let us say you are giving something in which action is cholinergic, but you have given an anticholinergic, for example, let us say Normaxin. Sorry to taking the brand name. Actually, each will antagonize the action of others. So drug interaction has to be carefully looked into and the mechanism has to be carefully looked into. It should not be the first go you give to prokinetic. One prokinetic, assess the improvement. Then if I really need a prokinetic, I'll give another later if it is needed.
I think, as sir rightly pointed out, that we have to also review the drug history of the patient which he is already taking, because many a times we have patients in our OPD who are undergoing psychiatric treatment elsewhere. They are on amitriptyline and having constipation, and we are trying to give them prucalopride or some other drug to relieve their constipation. So probably we need to screen and see that the patient is not on any other drug which can cause reduced GI motility. So if there are no other questions, we can close the session. Thank you everyone for patient listening, and our esteemed panel for their esteemed guidance. Thank you.
Thank you all the panelists and the speaker for such an elaborate discussion. Next in line, the last case of this iPhorum case series is a case of bloating. For this, as panelists, I would like to call upon the stage Dr. Sanjay Salunke, Dr. Mayank Jain, Dr. Venkata Krishnan Iyer, Dr. S.P. Mishra, and Dr. Rajiv Shandil. And for the discussant of the case, I would like to call upon the stage Dr. Sujit Chaudhary. There is an announcement that after this would be the last case in our iForum case series. After this, we would be having a short tea and coffee break. Thank you.
Good evening to everybody. So welcome all the learned panelists. So this is the last case of this iForum series. So this is a case of bloating. So the case history, this 35-year-old lady presented to me with the symptoms of abdominal bloating sensation for long duration, for about 3 to 4 years. These symptoms are severe for last 2 months, for which she is very much concerned and taking the consultation. She is complaining of bloating almost daily, and this bloating is more in the afternoon, and she feels when she is having these symptoms, along with that she is also having the symptoms of sense of tightness in the abdomen with tightness of the garments, and sometimes she feels that she has something that the feeling of she's as if she is having pregnancy feeling, that so much bloating. So this is having distension of abdomen along with the bloating. She had no history of significant pain, no vomiting, but she had some bowel disturbances. She was complaining of intermittent loose stool about 2 to 3 times per day, and also there is also intermittent in between constipation also. But she refuses to have the history of any significant weight loss. There is no history of any GI bleeding, and so then from the history of dietary history, she was having the milk intolerance since childhood, and she used to feel better when she stops milk and milk products. She likes vegetables, but she is taking both veg and non-veg foods. But she likes fruits and she likes sweets also. Personally, she is married. She is housewife. She has no addiction, and she has no history of any diabetes or hypertension or other comorbid illness. There is no history of any abdominal surgery. She is a bit anxious. According to her husband, she had sometimes mood disorders, for which she had to take some medicines earlier. But she had no family history of similar symptoms in her relatives. So I want to know, before going to the panelist, so what is the diagnosis according to from the audience? What should be the first diagnosis of this case? So I have enumerated the 4 diagnoses, and I want your opinion. What is the first choice? This is a case of functional dyspepsia with significant bloating. This is a case of irritable bowel syndrome with bloating. This is a case of small intestinal bacterial overgrowth. This is a case of lactose intolerance, as she complained that when is taking the milk, she is having aggravation of the symptoms. Or it is a case of pure functional abdominal bloating. Anybody from? Then I will ask the panelists to answer. So we go to any comment from the, otherwise I will go directly to the panelist. Dr. Mayank Jain, what is your diagnosis?
Sir, on noting the history, the patient has significant bloating for past many years with recent worsening. There is no pain abdomen, and she has some bowel symptoms in the form of diarrhea and constipation and definite history of milk intolerance. So most probably this is functional bloating. We do not have clarification on how is the bloating after meals. So whether it is postprandial fullness or whether the bloating is localized only to the upper abdomen is not clear via the history. And apart from this, since she has some bowel symptoms, probability of having bacterial overgrowth remains high, but she doesn't have pain. So the chances of having IBS are quite low. And many a times patients with functional dyspepsia can have bloating, but that history of whether it is a postprandial fullness is clearly missing. So I'm not sure about that.
Any comment from the other panelists? Any?
Yeah, the significant history of milk intolerance, that should be considered because she's definite about it.
Sorry, sir? Sorry?
About milk intolerance, lactose intolerance.
The lactose intolerance, see, actually, okay, definitely that is one of the or diagnosis, but that pure lactose intolerance should not be having so much bloating. And when she is off from the milk, so when she is avoiding, still she is having the abdomen
The sister was
bloating.
not coming. So if she's avoiding milk and it's still going, then probably she has functional distension, bloating and distension.
Yeah, she is having this problem even when she is avoiding milk.
Sir, I would differ slightly. Probably she has IBS with the bloating because she has significant bowel symptoms, alternating diarrhea and constipation. And also she has overlying anxiety and some comorbid psychiatric illnesses. And she has got milk intolerance.
Pain is not there.
Pardon?
Pain. Abdominal pain.
So pain is not present in this patient, but bowel disturbance, the definition keeps changing. So in this scenario with bowel dysfunction is a major factor which is there. So probably functional bloating I'll put second, and IBS with bloating would be first problem.
So for IBS, you have to have pain with change in bowel symptoms, change in bowel consistency, and relief or aggravation by bowel. So it has to be related to the bowel.
Actually,
pain or discomfort.
Dr. Ghoshal is not audible.
Yeah. Can't hear you.
Yes.
So Rome 3 says pain and discomfort. But see, you have to get a frequency. Rome 3 says at least 3 days a month. Rome 4, you have to have pain every week at least. Now, why this is important? Because this is important because you see there are two components. Is the pathology all in the gut, or is the pathology also in the visceral perception and brain? So IBS patient has perception issue. There is a reduced or visceral hypersensitivity. That's why they are reporting pain. Whereas functional bloating patient has a lot of issue here and less there. Though this patient had some anxiety, but forget about that. Much is here. So this is related to three things. One is diet. You see, food intolerance is there, lactose, vegetables. Second is microbiota, how this is fermenting the diet and producing gas. Just wait.
No problem with vegetables.
No, and third is motility, whether the gas is getting trapped in the small bowel. So accordingly you target, like if this patient had a lot of pain, I'll target very early with visceral neuromodulator. On the other hand, if the patient has a lot here, I will target the diet and microbiota. So these are important, and this is the message we wanted to give to everybody. Do not diagnose IBS if there is no pain.
Okay, so I think this is...
just a minute. Uday,
okay.
She had no problems with fruits and vegetables. Probably lactose and...
We keep on eating. The symptom really doesn't happen because I took vegetable and the bloating occurred. Bloating was occurring in the afternoon. What does it mean? Morning she is fine. She is loading her gut with foods. Which food is fermented and causing the gas production? You don't really know. That's why the bloating of gas-related issue typically will be more in the afternoon, less in the mornings. If the gut is empty. In the afternoon, you have poured gut with a lot of food and this is fermented. Which food got fermented to cause the bloating? You can't really say.
Is there any reason why the definition keeps changing? Pain and discomfort and then pain again.
That is very important question that you have asked. I think I don't also like this, but it happens because obviously it is decided by 80 to 100 people. And these are based on studies that are happening and the thresholds are changing. So at least physician and some of us gets confused because of this change, but this is not in our control.
So
actually, one point, there's a actually internal shift in the diagnosis. When IBS patients who have diarrhea with pain and discomfort, earlier they were called IBS in Rome 3. Now discomfort have been removed. Now the patients who have diarrhea and discomfort, they are called functional diarrhea now. They still are under functional bowel disorders. Maybe they wanted to limit the severe patients under IBS and the less severe under functional diarrhea and functional constipation.
So my issue was that in this patient, all the things might be working at one time. But when you say 1, 2, 3, it's very difficult to put in 1, 2, 3, and they're not watertight compartments.
Yes, you can't segregate. Yeah.
The overlap is always there.
Exactly.
And as Dr. Ghoshal had told in the morning, for Indian patients, these definitions may not actually be.
These are too stringent for our patients. Yeah. We don't see so much of pain in our patients here. People have discomfort and diarrhea.
Yeah, that's right. But ultimately, as Dr. Sobna said and Dr. Ravi Mittal said, that whatever is classification, these are not the base, they are not casted in the stone, but you have to follow something. So we follow something, and if we follow Rome 4, actually this patient surely has functional abdominal bloating and not IBS, probably in Rome 3 also. But look at pathophysiology to target the therapy. So let us go forward.
Okay, this is the so this is the functional abdominal bloating and distension as categorized by Rome 4 criteria, that these patients is having recurrent bloating and distension occurring at least 1 day per week on an average, with bloating and distension should be the predominant GI symptoms, as happened to this lady. The patient should not meet the criteria of irritable bowel syndrome, functional constipation, functional diarrhea, or postprandial distress syndrome. And the symptom onset should have occurred at least 6 months prior to the diagnosis, and symptoms should be active within the preceding 3 months. So all these criteria has been fulfilled by these ladies. So the diagnosis is functional abdominal bloating and distension. And this abdominal bloating is the subjective sensation of gas, trapped gas, and a feeling of pressure, but of being distended without any visible distension. But distension is the objective, as described by this lady, that physical manifestation of increase in the abdominal girth. So abdominal bloating and distension can occur independently, although they frequently coexist. About one study showed that about 50 to 60% of patients of bloating report abdominal distension. So not all the patients are having bloating or have abdominal distension. So these are the pathophysiology of gas and bloating. And already Dr. Ghoshal mentioned that what are the different mechanisms by which we are having this bloating sensation. This is maybe due to the gas in the proximal gut, stomach, then small intestine and large intestine. If there is gastroparesis, there is less motility, then there is bloating. If there is small intestinal trapping, if there is pseudo obstruction, if there is gut bacterial overgrowth, or even in the large intestine, the dysmotility, even fecal evacuation disorders. So the bloating and gas and bloating happens. So another thing, so the disorder in the gut microbiome, these are abnormal motility, small intestinal bacterial overgrowth, and another important is the visceral perception, abnormal viscerosomatic reflex, that also, and the other thing, the foods, the medications, and so all these are the multiple mechanisms by which the patient is having the symptoms of bloating. This is an important these mechanisms, that when there is excessive gas formation by gaseous distension of the GI tract, normally there is a viscerosomatic reflex. The diaphragm ascends and the abdominal muscle contracts, so that there is no, this is physiological, and that is not creating distension of abdomen or not creating the symptoms. But if this viscerosomatic reflex is abnormal, so when there is excessive gas, the diaphragm descends, and these increased in the intra-abdominal pressure, and abdominal wall relaxes and bulges out. And this is the mechanism by which there is bloating ultimately produces distension and produces discomfort. So this is called abdominophrenic dyssynergia. Along with that, there is visceral hypersensitivity. There is conscious perception of this intraluminal content and distension, and it is amplified by the brain gut neural, the neural pathway is activated, and this is influenced by the factors of anxiety, depression, somatization, and hypervigilance. So I want to ask Dr. Mishra, so how to approach a case of functional bloating like my patient?
Simple thing, I'll refer to Ghoshal. It's his head, not mine. But the other thing is, getting a workup over here is extensive.
Yeah.
So first, good clinical history. I'm worried about one thing, that she has the increase in symptoms for the last 2 months.
Yeah.
We haven't covered that.
Yeah.
So that may be a problem, but otherwise, she's not rule out hyperthyroidism, diabetes, clinically good clinical examination, maybe an upper GI endoscopy, lower GI endoscopy for the workup. And for SIBO, we have to do a workup. But by and large, clinically, I'll give her a trial of that. Listen to her well, counsel her attendants, try with probiotics and prokinetic, with rifaximin for some time, and maybe a little bit of amitriptyline. The only problem with amitriptyline can cause a bit of constipation.
Okay.
So any of the SSRIs can be of help. And I like to do a hydrogen bath test on her.
Thank you, sir. Also, and Dr. Salunke, just I want your opinion, what important organic cause, we have discussed this, we are discussing functional bloating. Definitely, there are a lot of causes of bloating, and what are the important organic cause we should think of excluding this? So what should be your approach?
So the metabolic causes, one of which you enumerated, thyroid as well as diabetes, I would definitely want to rule those out. And if you go from top to bottom, you're looking at stomach, whether that is contributing to this. So gastroparesis or anything that will cause gastric outlet obstruction, that could contribute to this, particularly those patients who are diabetics who would have gastroparesis as well as some pancreatic insufficiency, which would start allowing these things to happen downstream. Along with this, it could be SIBO, and there's one thing which is there in the food. If she's actually having fruits, so one thing which I would add is, if you can do a fructose intolerance, if you have a breath test, then probably you would be able to find out one cause which is contributing to it, and then you could advise an appropriate diet. The other thing is that some people, if they are constipated, like she is giving a history that there is some days she is constipated and some days she has normal or loose stools. This actually also tells me that there is likely to be a small bowel related problem, which in case any investigation does not show organic causes, then fermentation in the small bowel, as well as using medication to address slow transit constipation may probably be a part of the help in this.
Okay, thank you. Just to enumerate that, okay, this patient apparently is definitely there is no point to diagnose the organic causes, but we should exclude that organic diseases, particularly when we are managing case of bloating. The small intestinal bacterial overgrowth, the food intolerance, particularly lactose, fructose, and other carbohydrate intolerance. The celiac disease is an important cause. Pancreatic insufficiency already described. Prior GI surgery and can produce pseudo obstruction or organic obstruction, fundoplication, bariatric surgery, gastric outlet obstruction, gastroparesis. The bloating can be the ascites can be the first may present with bloating and gastrointestinal and gynecological malignancy, hypothyroidism. Just simple obesity can produce bloating. The abdominal obesity, small intestinal diverticulosis, chronic intestinal pseudo obstruction, idiopathic pseudo obstruction, and the disorders of gut brain interactions like irritable bowel syndrome, chronic idiopathic constipation, pelvic floor dysfunctions, functional dyspepsia, functional bloating. So these are the organic and functional disorder you should do in the consider in the differential diagnosis. So the case history, these patients on clinical examination, there was normal finding. The normal blood pressure, body weight was 71, BMI of 27, no malnutrition. Abdominal examination, soft, non-tender, no organomegaly, no visible distension of abdomen, and investigations, a normal hemogram and normal liver function test. Serology, the leaks, viral markers negative, liver function test was normal, sugar, lipids, creatinine, and also the celiac test there is normal, negative. Sonography was normal, gastroscopy is normal, colonoscopy was normal. So ultimately the diagnosis is functional abdominal distension and bloating. So what are the treatment approaches of this patient? Dr. Iyer, please.
So the concerns for this patient, the starts, when the patient enters the OPD, the first thing is to give a good amount of time to listen to the patient. That itself is that from that point onwards the therapy starts. So the concerns, the patient may have consulted multiple physicians, may have googled her symptoms, and may have a lot of concerns that whether this is cancer, whether this is so. First of all, listening to the symptoms and telling that it is because there are no red flag signs. Just from the history, we can say that the likelihood of having a bad diagnosis like a cancer or something is not there. So first of all, that moment itself, the patient becomes reassured and relaxed. After that, once we have ruled out all the organic causes, and then the treatment is, because the etiology is multifactorial, the treatment is also multi-pronged. So it starts with reassurance, then the dietary therapy to exclude, since she gives a history of lactose intolerance, to reduce and exclude lactose from her diet. A low FODMAP diet is the generally the recommendation for the patient. Hydrogen breath test, if done, if it is available, if it is done. If it is not available, then a trial of rifaximin and probiotics is useful. If that does not work, then we also have to target the visceral hypersensitivity by giving neuromodulators. One very important thing while while prescribing a patient neuromodulators is that they would go to the pharmacy and they would ask the pharmacist that what this medicine is. So they will say this is a medicine given to psychiatric patients. So you have to upfront tell them that this medicine is a neuromodulator. It is given for your gut symptoms and not for your not because you have any psychiatric illnesses. And if all this fails, then there are other approaches like biofeedback, complementary and alternative medications. Sometimes peppermint oil and cymbethicone, all these things also work. In worst case scenario, we may require to go her to go to a psychiatrist, which for some specialized therapies like hypnotherapy or CBT.
Okay.
Can I butt in a bit? See, I have, all of us get patients like this. They need to change their lifestyle. And you have to give them, what we call it in the younger days, extracurricular activities. So they have to be involved in that. Most of them have become, especially after COVID, उसको हम हिंदी में कहते हैं घर घुस्सू हो गए हैं. They're not getting out the house. Friends are not there. This is the only friend. So this problem has cropped up after COVID.
Yeah.
So you have to tell them, get out of the house, meet your friends, lead a good quality life, singing, music, pets. These are important things. So they are missing all those things because this is the big problem. Mobile is a big problem.
There's one more
Okay,
point.
sir.
Another
Yeah.
thing in this patient is that she's got long-standing symptoms. Now she has suddenly decompensated with her symptoms for 2 months. And that is what happens with most of the patients. They have been living with these symptoms for a long period of time, which is not giving them too much of discomfort. But when the discomfort level increases slightly, then they come. So when the tipping point comes, it's difficult to say whether they really have an organic disease or
Yes.
are we dealing with something which has been like functional for a very long period of time. So that is where the decision has to be made whether she goes for additional tests rather than upfront starting.
That was my concern, I said. 2 months.
Absolutely.
Yeah, actually, over here, this is where her symptoms increased, and we don't know whether she's calling it pain. And then we are talking about abdominophrenic dyssynergia. Now, if you have an acute GI event and the patient gets a post-infectious IBS, that's one road that the patient might evolve towards a functional disorder. But you might have a GI event where the patient had pain. So the genesis of abdominophrenic dyssynergia is pain which prevents the patient from allowing the diaphragm to accommodate. And then it becomes a learned response that they don't want that diaphragm to go out, and then there is a protuberant abdomen. This is how the bloating can start. Now, if this is worsened, and that is the last 2 months, where she may have had another minor diarrhea and it brought the patient to you. So, it may not always be an organic thing that has happened in the last 2 months. It may just have been a worsening of the functional disorder itself.
Yes, absolutely. This is possible that this is aggravated.
There'll
Another
be
functional
breathing
component.
problems will be there.
Most of these patients also do a lot of doctor shopping. So it is imperative for us to tell them that I am giving you the medicines with the best of my knowledge, but this is like a lock which has many keys. So we try each and every key, and if your lock doesn't open, then you come back to me. We'll keep short follow-ups, say 15 days or something.
That is what the patient is doing. She's going to many keys.
Okay. This patient was given the dietary advices to avoid these. Definitely, she was advised to avoid the milk and milk products, the high fructose containing foods, and then she was advised to advised to consult the dietitian so that she can guide you for a low FODMAP diet. And she was given this chart that these are the foods which you should avoid, which are containing high FODMAP foods, particularly the listed on the right side. And then she was given to follow the most of the foods. She should avoid wheat and wheat products, milk, then beans, lentils, fruit juice, apricot, and others. And she was advised to take rice and rice, and these are the vegetables she should take, and she can take fish. These common. By these, there was initial improvement. She was saying that okay, I tried, or I am trying it, but there is no satisfactory improvement of these with these low FODMAP dietary advice, though she followed it properly. So what could be the reason for this non-response to low FODMAP diet?
So the reason, basically, we have to understand that low FODMAP diet upfront doesn't work. That is one. Second thing is that it is too restrictive. Third thing is that only 50 to 80% people respond. So maybe up to 50% people may not respond. And because it is restrictive, it has got lots of, you have 10,000 things to eat in this world which are available to her. So a trained dietitian has to be considered most of the times, which is not available in 80% of the centers. And if that is something which is provided to the patient and the patient follows properly with the person, then only this will work. And you will have dietary deficiencies also with that, maybe related to calcium, some iron, and so there has to be adequate compensation done for that. And also, there are certain studies, as SIRS studies has also come about that FODMAP challenge test,
Yeah.
that they do with low FODMAP diet, they do a hydrogen breath test, and after that, after 3 days, they give a high FODMAP diet, and if that ppm it increases by 10, that probably it's got a high sensitivity up to 80%, and the positive predictive value is also about 75%. So that gives you an idea that this person is probably going to respond to low FODMAP diet. Otherwise, may not be a good idea of giving this low FODMAP diet. And it is a lifelong probably commitment to a restrictive diet. It has 3 phases. Later on, it can be personalized, but the person has to go through a very long process with a trained dietitian. So there are a lot of problems associated with following low FODMAP diet over a long period of time.
How many in the audience will not eat mango this
So-
season? You don't eat mangoes. A man go.
But this patient was very
So
categorical that
I want to comment from Dr. Ghoshal that what are the problems of what is the, and you know it is your test. Why should we go for FODMAP challenge test of this patient?
I have a contention that this patient was very categorical that she has symptoms only related to milk, and she tolerates fruits and vegetables very well. So why should we go for a low FODMAP diet? We can tell her to avoid just lactose.
She's enjoying fruits and vegetables.
So a more practical way would be to, make a chart of when she has a problem with which diet. So of course it is a little
She's
difficult.
saying milk.
He's saying
Yeah.
food diary. He's
Food
saying
diary.
Food diary.
So it should be rather if in patients who are not responding to a low FODMAP diet. So maybe an individualized,
Again,
tailor-made
a
diet.
recall is very difficult.
Sir, so that's why note down at that time.
Yeah, but only thing is that whenever you eat, immediately symptom doesn't occur. So what happens is, this is called gentle FODMAP diet. So instead of restricting all the FODMAP, you give only a few, restrict only a few. Now that is half-hearted. We don't really know how many patients would respond to a gentle FODMAP diet. Now the question is, should we do a FODMAP meal challenge test? My answer is no. Because FODMAP meal challenge test is done to predict response before you try low FODMAP diet. Here already you have tried low FODMAP diet, it did not work, therefore FODMAP meal challenge test is pointless. So how to treat then? Obviously you go further beyond FODMAPs. But before we go further, what we will like is to know how good was the compliance to the low FODMAP diet that you tried. So it is like, one is, yes, dietitian is very important, but more important is, I will ask the patient how compliant the patient was. Because non-response may be related to non-compliance.
Just like gluten-free diet.
Yeah, that's right. That's right.
Actually, that was also advised. The patient has gluten-free diet and these for. So ultimately, we thought that okay, as the patient needs further investigations, so hydrogen breath test was done, and it was positive. The hydrogen breath test was found to be positive, and then the patient was given a course of rifaximin, 550 milligram twice daily for 4 weeks, and the response was very good. So then I want to ask that whether we should continue rifaximin and when to stop rifaximin, whether according to the patient response, whether we can give further rifaximin. So from the comments from the panelist.
Yeah, I'll go ahead with rifaximin. If she is responding to anything, Sai Baba Bhabut bhi ho, good for her. I'll be very happy.
How many days?
Oh, continued for a very long time. Duration not specified.
I would think that after 4 weeks, if she has good symptom resolution, we'll give her an off period and see how whether her symptoms recur or not.
And she relapses and will not respond to it again.
So whether you need that the patient has relapse of symptoms after stopping the rifaximin, so and then what mentioned that whether we should go for a repeat breath test or whether we should that do the okay breath test is whether we corroborate with the duodenal aspirate culture and then we can consider the second line of antibiotics or repeat rifaximin again. So comment from the.
No, we have data on long-term rifaximin now. There's no problem, so we can continue that.
When the problem is the same, the remedy also remains the same.
Yeah, so I would repeat a course. I would not go for extensive testing.
Okay.
The only issue with rifaximin used in long term is the cost for the patient.
Oh, she'll
But-
gladly accept that cost.
Dr. Ghoshal?
Ghoshal, I have one problem. We had 1984 Manning's criteria towards a positive diagnosis of IBS. We should also have something towards a positive diagnosis of functional deterioration.
Yeah, and see whatever.
You keep on working these patients.
Yeah, so the question is, should we give a long-term rifaximin? I would say no. If the patient responded, then there is a chance he will remain well for next 3 months, at least according to the existing data. Then if you say, what is the chance of recurrence? Look at a study that Dr. Sanjeev Sajdeva did in GB Pant. Almost 50% will recur during this next 6 months. Now, in case of recurrence, what will you do? I would say repeat a course of rifaximin. What is the evidence for that? Target 3 study showed that if you repeat the course of rifaximin, it works as well. And in fact, when recurrence occurred in the Target 3 study, the severity of the symptom was much less. So you can keep on repeating maybe once, twice, or thrice. So this is what I will do. Now, how to prevent this recurrence? Mark Pimentel had a study which he showed that if you give prokinetic following rifaximin, the recurrence is prevented. Only thing is that this patient was having loose motion. So in presence of loose motion, I cannot give prokinetic. But if rifaximin response was associated with cure of the loose motion, then you can add a prokinetic to prevent the recurrence.
The other thing that this was hydrogen breath test was positive, but if it is negative, but you are suspecting SIBO, it is not that you know that it is not 100% specific. And then any other breath test, do you recommend or do you consider that other breath test should be done if the hydrogen breath test is negative?
To look for methane producing bacteria.
Mayank?
To look for methane producing bacteria, we can go for a breath methane test.
Okay, methane. Another thing, do you think that you have to go for the invasive test of duodenal aspirate will be to prove that this small bowel bacterial overgrowth?
That would be gold standard, but once she has already received a course of antibiotics.
If it is negative, actually, our breath test is negative.
Yeah.
Uday, what is the problem with long-term rifaximin?
See, long-term rifaximin, as you said correctly, that at least compared to the other antibiotic, rifaximin is not associated with so bad drug resistance. Like Mark Pimentel had one vitro study, one in vivo study. But only problem is, according to the current system in the world, you give for 2 weeks. See, cost is a concern. A lot of people will have skepticism to continue antibiotic indiscriminately. And if the fellow responded, we know 3-month response will last. So then why not to repeat after 3 months? So therefore, I would say that would be better strategy looking at the cost and skepticism among people.
Next step, the patient, as the response was not good even with rifaximin, the patient was given a neuromodulators like amitriptyline for 10 milligram at bedtime for 3 months, and there was significant improvement of her symptoms. And she had history of underlying anxiety disorders, and she responded to amitriptyline. So I think these are the algorithm approach for management of abdominal bloating and distension. The abdominal bloating and distension we have discussed that we should evaluate for alarm signs, and then we should consider whether there is overlapping for other functional GI disorders, the bacterial overgrowth syndrome, dietary intolerance, celiac disease, recent weight gain or constipation, and psychological disorder. If it is, if yes, you treat accordingly. If no, then reassurance. Recommend diaphragmatic breathing, as I mentioned that this is helps in the adaptation of this bloating. Dietary intervention, low FODMAP diet we have discussed. Symptomatic medical therapy, I have already discussed that you can try with peppermint oil or simethicone. If there is no response, that is trial of rifaximin and or probiotics. It has been found that the probiotics are not very much effective, particularly in this group of patients. There are some data, but apparently the meta-analysis showed that probiotics is not helpful for principally for abdominal bloating, distension, not very much helpful. Then you consider antidepressant, psychological therapy, hypnotherapy, or cognitive behavioral therapy. And if there is still the patient is not responding, you should consider like this biofeedback therapy, even the MR or CT based electromyography to improve the tone of the abdominal muscle and intercostal muscle and reduce the relaxation of that muscle and increase the tone of abdominal muscle. That is a part of the biofeedback therapy. So these are the options for managing a patients of significant abdominal bloating and distension. So final comments, the abdominal bloating and distension are highly prevalent symptoms and can negatively impact the quality of life and lead to medical consultations. Symptoms pose a unique diagnostic and therapeutic challenge, and there is no uniform diagnostic criteria or there is no uniform treatment algorithm for abdominal distension and bloating. You should think of a personalized evaluation is important, and the treatment should be planned accordingly to establish the addressing symptoms of bloating and distension.
Can I
So-
add one point?
Yeah.
It's from the panel. Alpha galactoside is something which, since this is a iPhorum session, for general practitioners, it's something which they use very, very frequently. And alpha galactoside is mentioned in the MDCP manual of Rome as one of the recommendations for bloating. So I mean, it could also be one thing which the message could go to the general practitioners, that for bloating it could be a very good intervention at their level.
And I have one very
All
practical.
enzymes.
When
You can, I mean, any of these enzymes which they contain a lot, many of them contain alpha galactosides.
And one very practical thing, most of the patients, they feel very well when they take metronidazole, and many of them continue with entroquinol even now. Even ask them to stop it, they're not going to stop it. And they feel very well, good about it. Uday, now your comment about this. You must have been having patients like this.
That is what I will discourage. Metronidazole is not a good drug, lot of side effect, particularly in long-term use, including
It's the patient's perspective.
No. Look at this, neuropathy. So I will educate the patient, do not take metronidazole. Entroquinol is a banned drug. I will educate the patient not to take, and then bring to the current science and will give rifaximin. That is one. Alpha galactoside is yes. Any of these enzyme that helps to digest the FODMAPs actually will reduce the amount of gas. Even there are studies with simethicone also, activated charcoal also, but they are not in the front line. For what reason,
Why
we
is
don't know.
entroquinol available even now?
That I cannot answer. Actually, you have to ask
banned. It's not
the
banned.
wrong person to ask.
Still available.
My question, sir. Hi. Rifaximin is a very safe antibiotic. It is poorly absorbed from the gut and so has very few side effects. So why is it not recommended during pregnancy? It is a category C drug.
Basically, not many studies have been conducted on pregnant females. That is why there is no recommendation as such.
The problem is lack of knowledge.
Lack of.
So are we done?
Okay. I think if there is no more question, thank you all, and thanks to all the panelists.
Any questions
And
from the
thanks.
audience?
And Dr. Subrata, hi.
These type of patients who are recurrently developed SIBO, and the patients comes to the general physician and also to us, and subsequently the patients are continue to take PPIs. So PPI is one of the major cause of small intestinal bacterial overgrowth. So that should be addressed, whether the patient is taking long-term PPI or not. So that is one thing that that can be addressed here.
Definitely PPI is one of the factor, but I think this type of functional bowel disorder is like functional dyspepsia or bloating. And if you are considering that SIBO is a factor, what we have in this case, we found that. So, but that I don't think that PPI is pathogenetically related to SIBO, because definitely PPI can precipitate, but it is what is the percentage of long-term PPI ultimately prove that to produce SIBO, it is not very common. And so definitely when you are considering this, PPI has to be avoided, or PPI should be discouraged in the part of the management.
Yes. And another thing is why these type of patients are continue to suffering from small intestinal bacterial overgrowth. Whether there is any immunological background is there or not, or there is any motility issues are there, that has to be addressed also.
Not every patient has it.
Actually, this is not that purely a small intestinal bacterial overgrowth. There are a lot of factors for these symptoms, as we have mentioned, that this is the intestinal visceral sensation, the neurological perception, this dyssynergy of the muscles. All these factors are producing the symptoms of bloating. So one of the factor is small intestinal bacterial overgrowth, but other important that the sensitivity of the small gut with some small amount of gas in the bloating, it is more sensitive. So for this, only thing that it is pure small intestinal bacterial overgrowth. It is one of the component in the pathogenesis of bloating.
This is regarding low FODMAP diet. So hello,
yes.
what exactly patient eats in a low FODMAP diet? Because if you see the chart, there's nothing left for them. You can't have rice, you can't have wheat. So we like Gushal to sort of
Yes.
put a light on this.
Dr. Kushal, when you are giving the chart, this everything is deprived of this.
Yeah, that is unfortunate. See, it is very difficult. This is very challenging. Particularly, we found if a patient is a vegetarian and you give him low FODMAP diet, practically asking him to stop everything. So rice is low FODMAP, Dr. Gulati. So you said you cannot have rice is not right. Rice is low FODMAP. There are some food which are low FODMAP which patient can eat. For example, rice.
He showed the chart of low FODMAP.
So what I'm saying, he said you cannot have rice, you cannot have wheat. That's why I'm saying. So rice is low FODMAP. Brinjal is low FODMAP. Corn is low FODMAP. Kiwi fruit is low FODMAP. Grapes are low FODMAP. All the non-veg foods are low FODMAP, be it fish, chicken, egg. So yes, there are not much left, but some are left. This is how we manage. Obviously, patient must be cursing us. We are also unhappy, but that is what it is.
Okay, I think, thank you all. Thank you. Okay.